from Barts and the London. Sorry, recording in progress. Do you want me to just start that again? And then you can edit the recording. Apologies, everyone, because they're going to reuse this. Hello, everybody. Welcome to the second International Online Symposium of the Knightsbridge Academy, Dubai, in collaboration with the College of Medicine and Dentistry. I'm Andrew Jackson from the College of Medicine and Dentistry, and delivering the introduction speech is Professor Maher Al-Masri. After completing a degree in dental surgery from Damascus University in 1995, Maher pursued a career in oral surgery at the Royal London Hospitals in London until 2003. He had an intensive year-long implant dentistry training at the Katharian Hospital in Stuttgart in Germany as an international scholar. He graduated with a master's and doctorate degree from Barts and the London School of Medicine and Dentistry, wherein he researched tissue regeneration and engineering. He developed an interest in surgical education and started a pioneering cadaveric model for training dentists in a safe, effective manner. In 2013, Maher founded and led BPP University's Faculty of Dentistry, which became one of the largest postgraduate dentistry departments in the UK and played a significant role in reforming dental private higher education. In parallel, he earned his MBA in Higher Education Management from the University College London. In addition, he has been actively involved in the development and support of research activities on an international level, including Austria, China, Egypt, Greece, Iran, Iraq, Italy, Pakistan, Saudi Arabia, Syria, and the UAE. Maher received an honorary professorship from the Bari University in Italy and full professorship title from BPP University. Thank you, Maher.
Thank you very much, Andrew. For some reason, I'm not able to share or start my video camera. It says the host has not enabled it. I think I might be now.
Maher, you are a co-host now, so you can share now, I think.
Thank you, Paula.
Can you try again? Thank you.
Can you see me now?
Yeah, we can see you.
Great, thank you very much. And I will be able to share my screen, yes. Wonderful. Thank you very much. Thank you, everyone. I hope you can see my screen with our college name on it.
Yeah, yes. we can see perfectly.
Thank you. I'm honored and glad for this invitation. Thank you very much, Bulent, for the invitation to introduce the College of Medicine and Dentistry in Birmingham and to host with yourself this symposium with the Knightsbridge Academy that basically is now hosted or housed in London, Istanbul, and in Dubai. And we're proud and we're very pleased to have this collaboration with you, Bulent, in this journey together. Okay, so I'm going to present some slides about the college, and then you will listen to lots of scientific talks by a number of key opinion leaders and basically leaders in the dentistry education in the UK and also, I understand, from Turkey as well. So the College of Medicine and Dentistry is the first and only independent provider in the UK teaching dentistry at master's and PhD levels. We trace the beginnings to 2013. We have lovely facilities in central Birmingham. We have education that is very much student-centered, and we have really high quality assurance. And we established 10 postgraduate programs at master's level. We have a vision to be the global leader of education and training dedicated to the professions, and that is in medicine, dentistry, and in healthcare, other healthcare professionals and healthcare divisions. We have a mission, uncompromised excellence, very much innovative education, and developing clinical leaders within the profession. Until now, we have lots of statistics since inception. We have at least 97% of our teaching staff, they have master's degrees or professional education qualification. We educate students from over 30 countries across the globe. We have reached in 2019 on its own at least 80% of dental professionals in the UK. We graduated hundreds of our MSc students. In 2019, we prepared more than 100 new dentists to the profession. We delivered education to over 100 dental care professionals, that's nurses, hygienists, therapists, and other professionals. And we communicated with over 200,000 dental professionals globally, international level between 2013 and now. Obviously, we have goals to be the most international college, teaching healthcare professionals, teaching doctors and dentists globally. We want to provide online solutions for education. Really would like to provide a wider scope from CPD levels to professional diplomas, MScs and PhDs, and we're currently doing all of this. And we have a goal of career support and employability support to students and graduates. And we'd like to diversify programs from all disciplines within the dentistry, medicine, pharmaceuticals, pharmacy, and other health divisions. So I just wanted to highlight one area of importance and one area of focus that we do highlight and emphasize on during our establishment during the past few years, and now more than ever. Why dentistry and why now? Dentistry, especially during the COVID and during the pandemic, dentistry did highlight the importance of the need of reform. So because of high risk of transmission of disease, many dentists undertook early retirement. And there are lots of publications that dentistry today is the same of the Middle Ages. So not many developments happened in many areas of dentistry, and therefore the need for innovation, and the need to reform dentistry and reform education. So hence we did focus on dental professions big time. We have professionals teaching professionals. So the teachers who teach in the college, they all professionals doing clinical work as we speak. We are very much close to the employers. I mean, example is the IDH, My Dentist, is the largest dental corporate in the UK. We have a close contact with them in a way. We have outstanding education experience, and that is evidenced by the feedback taken from students and the student experience. We're very much innovative in our education, and I'm sure Professor Raj Ryan, who is with us today, will tell you about the level of education that we have and how innovative it is. And from surgical education that I do complete to our students as well, we have cadaveric education that is very unique in the UK. We do support leadership because dentists, there needs to be leaders of any program, any organization they go to. And this is one of our early graduates and said that's the best, it's really the best dentistry education you can get. We have state-of-the-art dental hospital in centre Birmingham, open plan clinical pods and other private rooms. We have state-of-the-art simulation center with phantom heads, obviously seminar rooms and breakout area. We have established 10 programs from restorative to oral surgery to orthodontics, periodontics, facial aesthetics, endodontics, implantology, clinical diagnostic oral sciences, and we believe we are the only college to teach dental infection control at master's level globally as well. We provide education in digital dentistry, and the highlight of our programs was the Advanced General Dental Practice program, which was basically was shown big demand and interest at a global level. And we established this program to enhance the dental workforce in the UK. So the students who joining this program, they opt to establish a career in the UK as a dentist. They come and register as an MSc student for 1 year to full time, get a license to work as a dental therapist within that 1 year, get a focused tuition towards the license exam, that's the ORE and LDS, And eventually, after they finish the program in the 1 year time, they get a 2-year visa, in which they can work on a full-time basis after they're finishing the program. But why we developed this program? Because there's a big demand for dentists in the UK. I mean, this is even before the pandemic. There's a 22% shortage in the UK dentistry workforce. Dental therapist is another area of shortage. Dental therapist is a rank of dentistry or individuals. They work under a certain scope of practice. They are not dentists. They're not hygienists, but they can do conservative work and hygiene work. I'm sure my colleagues can explain those. They can do extraoral assessment, can do periodontal treatment, they can do restorative treatment within certain scope. It doesn't involve dental pulp, and it doesn't involve laboratory work, so very much conservative treatment. And they can do radiography and take impressions, etc. And those that are working as dental therapists, there's big demand on them currently in the UK. Dental therapist income can vary from £30,000 per year up to basically more than £43,000 per year if they're working as a private therapist. £30,000 to £37,000 if they're working within the NHS. That's statistical data from prospects.ac.uk. And if they manage to get into the dental register as dentists, so their income varies from £50,000 to £110,000. And if they are in the NHS, they can start from £30,000 as well as NHS trainees, etc. And that's also in the prospects.ac.uk. If they work as consultants, they can go up to £107,000. The course of MSc in Advanced General Dental Practice is a modular course. It has many aspects of basic sciences, examinations, diagnosis, treatment, clinical skills in holistic and multidisciplinary patient care, fundamentals to restorative, dental implantology as well, digital dentistry, contemporary approach to dentistry, the importance of governance, management, and administration. And of course, you will have, and you will end up with a dissertation at the end of the year. We also have a program that is focused only on the RE and LDS skills. That's a license exams, which leads to being licensed in the UK. And we have programs that leads only to registration as a dental therapist in the UK, which includes mentorship and fill all the gaps for prior education, etc. So that is the course structure, which that you start at MSc level at registration or enrollment. Then within 4 to 6 weeks, you will complete the application for the dental therapist. We expect people within 4 months to be registered as therapists, and then they would do lots of intensive education in RE, LDS, restorative dentistry, multidisciplinary approach to dentistry, holistic approach to dentistry, etc. And they end up in 1 year with the MSc degree. So the benefits and objectives of this program, that they study advanced dentistry, advanced general dental practice. They earn an MSc degree within 1 year. They have focused training on RE and LDS skills, register as a dental therapist within the course, earn while they study as dental therapist, because if they manage to register as dental therapist, there are lots of work opportunities as dental therapists while they're studying, and that will enhance their chance to pass the RE exam later on. Get a work visa for 2 years after the course, introduced in a way to the UK world of dentistry. And this is a stepping stone and the prospect for a career in the UK as a dentist. So I'm sure Bulent and his team will tell you about the easy-go approach if you want to become a registered dental therapist within a few weeks' time, within a program that is based on a few weeks. I'm not going to take questions and answers. I'm conscious about the time because The professors are waiting to provide you with important lectures of this symposium. Again, thank you very much, Poland and Knightsbridge Academy for hosting me in this webinar, and I'll leave it to you, Andrew, to introduce the speakers.
Thank you very much, Maher, for that wonderful introduction. So our first lecture is from Professor Shamir Mehta. Shamir qualified from King's College in London in 1996 and completed his Masters in Clinical Dentistry in Fixed and Removable Prosthodontics in 2005. He is a partner in 2 mixed dental practices in Northwest London, the Deputy Programme Director of the MSc in Aesthetic Dentistry at King's College London, the Senior Clinical Lecturer Advisor Fitness to Practice for the General Dental Council, and a researcher at Radboud UMC, Nijmegen, and the Netherlands. He has gained publications in numerous peer-reviewed journals and is the co-author of 2 textbooks, written several book chapters, a panel member for the European Expert Consensus Panel on Severe Tooth Wear, and part of the Radboud Tooth Wear Project Group. He is also an examiner for King's College London, a member of the FGDP UK Academy, a facilitator for FFGDP, and a reviewer at the Centre for Advanced Practice Health Education England, which is HEE. The lecture is on restoration of the worn dentition, an evidence-based approach. Thank you.
Thank you, Andrew. Can I just confirm that you can see the slide?
Yes, we can.
Yeah.
Okay, great. Thank you. So my talk today is on the restoration of the worn dentition, taking an evidence-based approach. So my interest in tooth wear started about 20 years ago, and that led to the publication of a 4-part series in the BDJ in 2012. And on the back of that, I was invited to a European consensus meeting in 2016 in Nijmegen, Netherlands. And from that emerged a consensus statement, which was published in the Journal of Adhesive Dentistry. And for anyone interested in tooth wear management, this is something that I would strongly recommend as a reading source. And throughout this lecture today, I'll be making recurrent reference to this paper. So I'm a general dentist, and I suspect many of you attending this meeting today are too. And in my experience, and I'm sure it's not I'm sure it's the same with you as well, I'm seeing more and more cases of tooth wear year on year. To give you an example, these were just some cases I saw just before the start of the pandemic, within a relatively short period of time. And I guess the question we ask ourselves is, why is this? And this is quite obvious when we look at the epidemiology of tooth wear. And I've highlighted a number of studies here, although there are many, many. The 2009 UK Adult Dental Health Survey, which reported signs of anterior tooth wear amongst 77% of a sample of about 5,500 dentate adults. Now, in the UK, we have an aging population, and it would seem logical, with people holding their teeth into later years, that we're going to see signs of tooth wear. But the problem of tooth wear is not limited to older adults. Other studies have shown high prevalence rates of about 30% on the buccal and lingual surfaces amongst younger European adults, with the UK having very high levels, or the highest levels amongst the countries included in this study, which was probably related to the UK population's preference for spicy foods. But again, the problem is not limited to adults only. Global prevalence rates have shown an estimated global prevalence of about 30 to 50% of tooth wear amongst the deciduous dentition. And again, this is probably related to lifestyle change. Late 1990s, the consumption of fizzy drinks, which are largely contributory to sort of erosive wear, has gone up by about 7-fold, with a large amount of consumption amongst a sort of teenage year of patients that we see. Tooth wear is different from caries and periodontal disease, and just out of interest, it's the third most common form of oral disease after caries and periodontal disease. But it's different in that tooth wear takes place as part of the natural aging process, whereas the other two conditions don't. And therefore, this makes this a lot more challenging, where there's a need to define physiological wear or distinguish that from what's not physiological, with physiological wear being normal age-related wear of teeth. And some studies have done some measurements in terms of what that would be. In contrast, we have pathological wear, and pathology, usually the term implies some form of disease. And this was defined in the European consensus meeting as tooth wear causing pain or discomfort, functional problems, or deterioration in aesthetic appearance, which if progressing may rise to undesirable complications of increasing complexity and is atypical for the age of the patient. So that distinguishes pathological wear from physiological wear. But we then have patients who have tooth wear with no pathology, no symptoms, etc. And you will see signs of tooth wear. And for this, as part of the consensus meeting, the term severe tooth wear was defined, which was tooth wear with substantial loss of tooth structure, with significant loss with 1/3 or more of the clinical crown. And this description is quite helpful when we're looking at sort of indices that are used for scoring and grading. So let's just have a look at a few examples, because it's quite important to understand what we're talking about as tooth wear. This is an example of pathological but not severe tooth wear with an adolescent who we would all agree as experienced clinicians that there isn't signs of severe wear, but this patient had symptoms of sensitivity. Here we've got a case of an 83-year-old male patient with severe tooth wear, but is not pathological. Patient has got no symptoms, no concerns whatsoever. And it's in this level of air, one could perhaps say is typical for age. But then you can have tooth wear which is pathological and severe. And here is an example with quite advanced wear, where the wear present is also causing symptoms and concerns for the patient. So using these descriptions, a flow diagram was presented as part of this consensus statement. And I found this very useful. Certainly when I was a younger dentist, I would get very confused about what to do with these sorts of patients. And in essence, where you've examined the patient, and if you deem the wear to be physiological, then nothing really further needs to be done. If the type of tooth wear is pathological and or severe, then there would be the need to carry out risk assessment, identify the etiological factors, document the level of wear present, and that would usually be followed by an appropriate preventive program with counseling and monitoring. And with that in place, you would then undertake an assessment for the need for restorative rehabilitation if the wear is a concern for the patient and or the clinician. And today's lecture is going to largely focus on the restorative side with sort of a reference to the evidence base. But before we get to that, as I said, an important thing is for patients with tooth wear to try and identify the etiology. Now, we know that tooth wear has a multifactorial etiology, and evidence has shown that erosive factors are involved in about 80% of the cases. And lots of different sort of classifications of the etiology has been described. In a recent textbook, myself and my co-authors have described 4 primary mechanisms. One is mechanical intrinsic tooth wear, which is tooth wear which takes place as a result of chewing or bruxism, what we often call attrition. The other is mechanical extrinsic tooth wear, which is due to factors other than chewing and or bruxism, often referred to as abrasion. Chemical intrinsic tooth wear, which is a result of gastric acid, erosion. And chemical extrinsic dental tooth wear as a result of an acidic diet, also known as erosion. And having identified what the likely cause is, you would use that information to give a targeted preventive treatment plan. Now, I'm not going to go into that because that's a lecture in itself, but if you've got interest in that, we recently published a paper in the update about the prevention of wear, taking an evidence-based approach. In fact, with doing my research, when writing this, I came across quite a lot of interesting observations, and this is certainly worth a read if you've got an interest in knowing more about the prevention of tooth wear. Now, as I said, once you've identified the etiology and provided a preventive plan, the next thing is going to be to monitor the progression of the disease to see if your preventive plan is effective or not, and to assess the rate of progression. This can usually be done by chair-side evaluation, typically using an index. The basic erosive wear examination is one that's quite a simple and practical one to use. Then there's the tooth wear index of Smith and Knight, and one which is used quite a bit in the Netherlands is a tooth wear evaluation system. But there are over 110 different types of tooth wear indices, so a lot to choose from, unfortunately. Sometimes it can be quite difficult to use an index to score every single tooth and surface with the patient in the chair. So you can take study models, gypsum casts, and undertake assessments using an index, or even making a sort of a silicon index, as we do when we sort of make provisional crowns or composite build-ups, to see if you can assess levels of wear using that. Nowadays, with more and more of us using intraoral scanners, you can obtain digital models and use an index using that. And you know, I suspect in the future, sort of subtraction software will be available where you'll be able to actually measure levels of wear at particular points, reference points on a tooth, and that will help with the treatment planning. And of course, there's the option of using photographs, and these are a good sort of a visual aid and can be used alongside indices as well. So there are various different tools that can be used to monitor wear. And in general, when you see a patient with more severe forms of wear, after giving the preventive plan, it's a good idea to undertake some kind of observation before diving into restorative treatment, because if you don't manage to control the etiology very well, it's highly likely that the restorative plan will fail prematurely. There are some exceptions. For example, a patient with very rapid wear from an eating disorder, etc., that might sort of fast track things along. But in general, a period of observation, which also allows you to develop a relationship with the patient and explain complex restorative plans, as you'll see in a minute, and ensure that they understand what you're proposing. But there are going to be some cases where simply throwing fluoride and providing splints is not going to be enough, and where active restorative intervention is going to be needed. And generally, these are where there might be aesthetic concerns, functional concerns with phonetics and chewing, for instance, or patients complaining of discomfort, or, as I said before, where the level of wear is very aggressive and a concern for the patient, clinician, or both. Now, before I sort of dive into the sort of clinical aspect and showing some cases, I thought I'd just discuss the philosophy for managing wear cases. Now, there are two ways, if you like, to skin the cat. One is taking a conventional approach, which usually involves a prescription of multiple units of crowns and onlays. The other is an additive or minimally invasive approach. And especially now with the availability of predictable materials that we can bond to effectively glue back what has been lost. And I'm just going to explore these two. And as I've got at the bottom, they're not mutually exclusive. It's in many cases, you end up using a combination. But if we look at the conventional, the traditional way of treating wear cases restoratively, to place a crown on a tooth, we know for a tooth-colored crown, we're looking at studies from Edelhoff and Sorensen that there may be the need to remove 60 to 70% of hard tissue volume to accommodate a restoration. Now, when we're looking at treating a worn tooth, that really doesn't make sense. In contrast, the additive process is minimally invasive. With conventional crown work, we know that there are risks of pulp tissue damage, estimated to be 10 to 20% in the literature. Again, with the minimally invasive approach, this is likely to be minimal. We also know that preparing crowns is irreversible in terms of having done the preparation. And we know that some patients, unfortunately, at times do not adapt to complex occlusal and aesthetic changes. And therefore, that becomes a minefield in itself. The use of a minimally invasive technique gives some sort of contingency planning in that it's not reversible as such, but you may be able to remove what you've placed with minimum damage or minimal damage, if you like. But of course, it's important to gain consent for whatever you do. Conventional crowns require copious amounts of coronal tissue for retention resistance. Of course, for adhesive work, there's a need for a good quantity and quality of enamel. With conventional work, we again are looking at provisional temporary crowns, which adds to the cost and the complexity. For adhesive work, there's a need for good moisture control. And in relation to the matter of cost, we estimate that the treatment using conventional crowns is substantially more expensive than going in with a sort of a minimally invasive approach. And the use of materials like composite, as you'll see from my cases, allows you to almost give your patients, almost test drive the changes that you're proposing in a sort of a more minimally invasive, a more predictable way. And we know that you can adjust composite by taking some away or bonding some more material to it to sort of help tweak whatever you've provided to fine tune your restorative prescription. And this is kind of this view, this philosophy is embraced in the consensus statement, whereby effectively, if we look at the second paragraph, restorative treatment should be as conservative as possible, employing minimally invasive strategies, applying a dynamic restorative concept. And whatever we do, whether it may be conventional or adhesive, of course, emphasis is on the importance of attaining informed consent and ensuring the patient understands the full risks, the benefits, prognosis, et cetera, et cetera. So for just sort of descriptive purposes, I'm going to divide the wear case into localized and generalized cases. So here we have the first clinical case. It's a chap that I saw a couple of years back in his early 40s. You can see that he's got sort of moderate to severe wear, affecting largely his anterior teeth, both upper and lower. And he had concerns with the aesthetic appearance. Now, if we're looking at the restoration of this, essentially, we've got three approaches we can take. One would be to restore in the intercuspal position when the teeth are maximally meshed together. Now, of course, we're not going to restore teeth which are not worn down. But if we were to restore the anterior teeth, we would find that back teeth no longer come together unless we place conventional crowns. So restoring in the intercuspal position, usually for wear cases, is not possible unless the patient may have an anterior open bite or a posterior open bite, for instance. In some patients, there is a slide between the maximum intercuspal position and the first point of contact in centric relation, when the mandible is manipulated into centric relation into a more distal position, or what we call the distalization of the mandible. And sometimes that creates enough space to allow you to put your materials in, to bond materials into place without opening the bite and creating a new position which is not physiological. So of course, if we're taking this reorganized sort of approach, as we see in point 2, is within the physiological parameters. So that would be another approach. You would accept my word, in this particular case, that room wasn't available. But that kind of emphasizes the need to take mounted study casts to allow you to study the occlusion with the casts mounted in centric relation without the effect of the neuromuscular reflexes, the tongue, the cheeks, so on and so forth. The third approach, given that we want to treat this in a minimally invasive way, was to basically put the restorations proud of the bite, or what we call in supra-occlusion, utilizing what's commonly known as the Dahl concept or relative axial movement. And that is what was done in this particular case. So here we have a wax up, and the planning of the wax up is a series of lectures in itself. But to just point out to you, we've waxed up the teeth according to the patient's aesthetic requirements and what we think will be a stable occlusal position. I'll come back to that later on. But where you can see with the arrow there is a space there between the back teeth once the wax up is being done. And the idea with this dial approach would be that in time, those back teeth will come together through the process of condylar repositioning through some intrusion of the anterior dentoalveolar segments and extrusion of the posterior segments. And this case, which is not just limited to localized anterior wear, there are some back teeth with wear, the lower left first molar. Whilst we've opened the bite, we have the opportunity to restore that in a minimally invasive way, and you will see that in a minute. So here we have the case, the wax up was done, and a silicone key was made from the wax up, which you can see at the top of the screen, a bit like when you do your class 4 anterior composite restorations. And that key, which copied the occlusal prescription on the wax up, is being used to layer composite in a minimally invasive way. And with this particular case, there was no tooth subtraction or no macroscopic tooth subtraction using any burrs beforehand. And what we find here is that we've got the opportunity to provide an aesthetic occlusal prescription by minimal intervention using some of the really good materials that we have available. As I said, that there was a lower left first molar where there was wear, and I took the opportunity to simply prepare a margin, and a gold hat was bonded into place. And there was a crown on the other side, which was simply replaced with leaking margins. I took the opportunity to build the lower anterior teeth in exactly the same way, other than the deciduous tooth, which was discussed at detail beforehand, where the patient didn't want to have it extracted, and simply a sort of a composite mask has been applied there. And here is the same case three months after. And what we can see is that the back teeth have come together on the lower images, and the occlusion tested using shim stock. And we can see the presence of even centric stops all the way around. And we can see on the top right the presence of a canine guided occlusion. And these are the sort of occlusal endpoints that we would be looking at with these sort of cases, which helps us to sort of establish this going to be stability. But the thing I want you to focus on is that the teeth have come back together after a period of 3 months. And this technique, this dial approach, which some of you may have heard about, it's not limited to the use of resin composite. You can use all sorts of other materials. In this case, which in fact I treated, these were placed in 2006 and reviewed several years later. In this case, I've used metal platal shims. These are made from nickel chromium, similar to what can be used for crown and bridge alloys. You can use type 3 or type 4 gold as well, and I'll talk about that a little bit more later on. And this gives a sort of a robust alternative where the restorations can be fabricated at quite a thin sort of thickness, if you like, and it can give quite a durable, predictable outcome. You notice there that I've got some cingulum rests. Nowadays, we wouldn't usually provide those. One of the risks with this approach is obviously the dulling of the teeth, which you can see, but therefore the use of this would be really limited to where the pattern of wear is more on the palatal side with minimal incisal edge loss. And there is some evidence, a study by Knoll, which I've put at the bottom, of a good success rate of roughly 90%, where they looked at 201 metal palatal veneers observed for a period of just under 5 years. So this can be another approach to the management. And again, these can be put proud of the bite. And this metal is similar to what you would use for your resin bonded bridges, your Maryland bridges, etc. So let's look at the dial concept, as I said, often known as relative axial movement or occlusal adaptation. This is nothing new. It was developed in the mid-70s, where the team used a removable cobalt chrome appliance on patients with wear. And essentially this appliance was an anterior bite platform with cingulum areas, and it resulted in increasing the vertical dimension of the occlusion by about 2 to 3 millimeters. The appliance was worn continually for several months until the back teeth came back together again. And the space created at the front by the back teeth coming together could then be utilized to place restorations in without effectively drilling away or taking away any further tooth tissue where obviously a lot of injury had already taken place. And what they reported, or what has been reported, is that with these sorts of cases, occlusal context usually re-established within 4 to 6 months, but it can take a lot longer, up to 2 years. And as I said before, the process involves a combination of initial condylar repositioning, followed by intrusive 40% and extrusive 60% movements of the dentoalveolar segments. The overall evidence seems to suggest a success rate of 94 to 100% with the use of this DAL approach, irrespective of age and gender. And one of the things that we now know, and you notice that my cases involve the use of bonded restorations, is that we've kind of moved away as a profession from using removable appliances, largely because of issues with compliance. And the evolution was to move away from that to then move on to the metallic type restorations that I showed, which was cemented into place, to now using composite, which offers an aesthetic approach. And we also know from the evidence that we have that in applying restorations in this way, with careful case selection, that adverse effects, pulpal conditions, periodontal disease, TMJ problems, etc., apical problems usually are not observed. But the key thing with success with this is careful case selection. There are going to be some cases where putting restorations in supraocclusion and expecting a predictable outcome, it may not happen. And these are cases with limited eruptive potential. And these are cases where you would think very, very strongly about taking this approach where it may fail. And these are ones where there may be an anterior open bite, posterior open bite, patients with bony exostosis, where there might be signs of ankylosis, such as with an implant retained restoration, where there might be fixed bridge work with sort of either end, not a cantilever design, and in cases of severe class 3 malocclusion. So these are the sort of cases, if you come across patients like this, you've got to think very carefully about using this treatment approach. There are also some pre-existing conditions which may contraindicate placement. And this might be if your patient has already got TMJ related problems, there's a risk of making things worse. If there's active periodontal disease, where there might be endodontic treatment to the teeth, or where the opposing tooth may be heavily restored, where placing an opposing restoration in supraocclusion may increase the risk of a fracture, for instance, or where the patient may have had orthodontic treatment in the past, where disengaging the occlusion for prolonged periods of time may lead to relapse. So there are certain sort of alarm factors that need to be considered when sort of prescribing this form of treatment as well. Now, much of the evidence that's available, or in fact, all of the evidence, as far as I'm aware, in relation to tooth wear, all relates to the placement of dial restorations at anterior teeth. There is some work ongoing for posterior restorations, and we hope to publish that in due course. But what I'd like to sort of bring to your attention is a study which I did with my colleagues in 2014, where we utilized the DAL approach of putting restorations proud for the minimally invasive management of cracked tooth syndrome. Now, at the outset, for someone who hasn't heard this concept, it would sound quite wacky, putting in a restoration proud on a tooth with a crack. But without going into too much details, what I wanted to tell you or discuss or share with you are the outcomes of this study, where we found putting a single restoration in supraocclusion at the posterior teeth amongst a sample of 140 patients, where obviously we applied careful case selection, as I've discussed. We found that in 97% of our sample, the posterior teeth reestablished contact within 3 months, and out of interest, it was 97% successful for the minimally invasive diagnosis and management of cracked tooth syndrome. But this might be a paper that you might be interested in. It was published in the Journal of Dentistry in 2014. So the DAL concept is by no means limited to anterior teeth, and no means limited to tooth wear management. You may also use it to place in restorations in supraocclusion, such as resin bonded bridges provided with minimal intervention. So let's move along to generalized tooth wear. Now, traditionally, sort of a prosthodontic teaching, patients with generalized tooth wear were put in one of three categories based on this proposal from Turner and his colleague. Category 1 patients are where there's excessive wear with the loss of vertical dimension of occlusion. Now, these are cases where we know that our patients normally have a freeway space of 2 to 4 millimeters. These are cases where the rate of wear is usually very high and exceeds that of the compensation. You notice with the other case that certainly that patient with wear wasn't born with teeth like that, but you notice that his teeth were making contact. And that happens because of this dentoalveolar compensation, where due to growth of the dentoalveolar segments and cementum deposition, the teeth will want to maintain patent occlusal contacts. But for these category 1 patients, the level of wear is such that it exceeds the rate of dentoalveolar compensation. So the freeway space is likely to be bigger than your 4 millimeters. Category 2 are ones where there isn't that loss of vertical dimension, but there may be space available elsewhere. And I'll show you some examples. Category 3 is where there is excessive wear with no space available anywhere. And those are the most difficult ones that we come across. So if we look at category 1, if I show you an example, this is a chap that I saw a couple of years back again, in his late 30s, and he had a generalized wear with a love of fizzy drinks and a highly stressful life. And doing a basic assessment, he had a 6 millimeter freeway space. And that kind of told me that I've got room available there to place materials in a minimally invasive way, in an additive way, to add back to those worn surfaces without the risk of violating that physiological freeway space. So again, some diagnostic work was done, some wax ups at the increased OVD. And those wax ups were indexed in the anterior. And I usually start off by restoring the anterior dentition first, establishing the required aesthetics and the anterior guidance, and ensuring that I've got enough room for the back restoration. So the front teeth were built up using composite in a minimally invasive way, layering to try and get a good aesthetic result. And having done that, you can see on the top left, on the bottom left, where the retractor is present, that there is room available now, created by the building up of those anterior teeth. And that room gives me some space, or the space that I need, to put in an occlusal veneer or an occlusal onlay with minimal tooth reduction. And here we see I've prepared some finishing margins on the right-hand side. And the same has been done on the left-hand side. Now, a lot of people ask me about sort of provisionalization. What I tend to do is to use the wax up to produce an index and then just use a provisional crown and bridge material. I think in this case, it was ProTemp. The restorations are linked, which is obviously not ideal, but there's enough space there to get a interproximal brush through. And these were cemented in using zinc polycarboxylate. Now, obviously, material selection is very important. And I know that the ceramics are evolving all the time. I don't have much experience with zirconia, but I have used Emax. But I'm a bit nervous about using Emax on posterior teeth. There's a lot of experts in the tooth wear field are. I'm quite happy to use them on premolars, but not as much on molars, and we'll discuss that in a minute. My preference for restoring molars is using gold onlays. And if you're going to use gold onlays like this, this is a type 3, it's important to ensure that the fit surface is oxidized by doing heat treatment or doing electroplating, because gold is a precious metal with a low surface energy and will not bond well to resins such as Panavia unless that surface is appropriately treated. And just going back to that, we know that with the use of gold onlays, with the very limited evidence available, the use of these restorations in a study done by Harpal Channa, good success rates, 90% were reported over a period of 5 years. And that's my own sort of, if you like, clinical experience, does give quite a predictable approach. And here we see these onlays that were all bonded on one occasion. And here we see the post-operative result, centric stops all the way around, where the centric occlusion is coincident with the centric relation. There's canine guided disclusion. And that's what we refer to as the mutually protective occlusal scheme, with shared contacts between the front teeth and protrusion where the back teeth separate. Now, the other type, category 2, is where there won't be space in the vertical dimension, but space may be available elsewhere. And this is, again, when you manipulate your patient into centric relation by the distalization of the mandible, you may well find, and you'll see that in the next slide, that or in the slide after that, some space will be available, and you can use that space to restore that patient in a physiological position. Traditionally, the approach was to provide these patients with a removable occlusal scheme with the new height and the mechanics of the mutually protected occlusal scheme by fitting them with a Michigan appliance or a Tanner appliance, a hard, full coverage acrylic splint. And these would usually be worn for a period of 1 to 3 months all the time, other than when eating, to ascertain whether the patient can tolerate these changes that you're proposing. This was a case that I did, again, quite a few years ago. I unfortunately don't have the picture of the splint in situ, but he was given a Michigan upper splint to wear, got along with it very well. And we decided to restore all of these teeth indirectly in one visit. So we had some indirect composite overlays made for the anterior teeth where they were wear, and posterior gold onlays that were used to include the premolars, which was his preference. Of course, what can now be done is you can have your gold hat made slightly sort of thinner on the buccal face and actually bond, mask the gold using masking techniques and bond some composite across should you wish. But again, that's a lecture in itself. But this was a case where the patient was given the splint, got along with it well, and those occlusal features were copied across into the definitive restorations. This is another case of a category 2, and this patient had wear in his late 50s. And as I said, my sort of usual approach is to have some mounted casts on a semi-adjustable articulator. And this, you can see that there's some room available when the mandible is distalized to give me space to bond my material into without increasing his occlusal vertical dimension into a position which is not physiological. Wax up was done, and the idea is that we've got an endpoint, which is the mutually protective occlusal scheme, as I said, with even centric stops, posterior tooth separation on protrusion and excursion, with canine guidance and shared contacts in protrusion. And as with the other cases, the wax up was used to produce a silicon key, which was used to apply composite in a layered fashion, doing the upper teeth and the lower teeth. And then in this particular case, in fact, what I forgot to mention, why I'm showing you this case, what we've realized is tolerance with splints is not very good. A lot of patients don't want to wear them. They want to have the treatment done sooner. There's a cost of the appliance, so on and so forth. What we now know with using materials such as composite, why not bond a Michigan splint into place effectively, if you like, by building the teeth up using composite to establish the same occlusal endpoint as you would do with a splint. And that's the approach that was done here. And what I started to do is to build the back teeth using composite as well. And normally you'd keep the composite restorations quite flat, as you'll see in the next picture. But what I found is I got towards the premolars, and I'm a general dentist like many of you, and we come across the same difficulties. The patient was getting along very well. And then I decided to just put some gold hats on the back teeth, because it's getting quite difficult to keep this patient's mouth open for prolonged periods of time. And here we see the end point. The worn posterior teeth have been restored with a combination of flat posterior composite restorations with centric stops, and gold hats were placed at the molar teeth. But There's nothing stopping you from restoring all of the teeth using composite and eventually substituting that composite for a more durable, more robust, more expensive material once you know that the patient has adapted to the complex changes that you're proposing. This is the third category, and these are cases where there's no room at all, and these are the sort of patients that you kind of hope don't walk through your door very often because they are very, very difficult to treat. This was a case, again, saw 12 years ago. This was in fact a family friend, and it's always difficult turning away family friends, I'm sure you're aware. This patient didn't want to wear a splint. There was no room elsewhere. Traditionally, these cases would be treated using approaches such as crown lengthening and conventional crown work. But you and I probably both know that, if we're going to prepare those lower teeth that you see there for crown work, the likelihood is that we'll be, visualizing the pulp. And the approach now, and the approach that I took, certainly in the Netherlands where I do research, is to kind of do away with this traditional category 1, 2, 3 approach, but to use composite to just build these teeth up. And we know that the tolerance is usually pretty good with this. And that's what was done here. With the patient's consent, the teeth were built up just using direct composite at the front teeth. And what I did at the back teeth was I had some indirect composite onlays made, and these were cemented into place. And it was really a way of seeing if this patient could sort of adapt to the planned occlusal aesthetic changes. This was done a long while back, and materials are a lot better than what was available then. Now, at the outset, knowing that the forces at the molars are 9 times higher than at the anterior teeth, and about twice that at the premolar teeth, and this was one of those patients who could probably damage a golf ball if you gave one to him. Knowing that, and I went through the consent process very carefully, at the back of my mind, I knew that the composite restorations that were going to go in the back teeth were not going to last as long as the front teeth. But as I said, this approach gave me the opportunity to evaluate whether he could tolerate these changes. And in the least, putting this material across those surfaces helped to protect them. And this is pretty much what I found. If you look at the lower picture, within about 2 years, and the lower picture was taken in 2011, the composite started to wear. And this is what I had expected. But now, knowing that the patient can accept what I've done, and he's happy, he's able to chew without any problems, etc., I can use conventional crown restorations by simply cutting back the composites and using techniques such as a customized guidance table to copy that scheme into a crown restoration, which otherwise, if it's incorrect, can be very difficult to modify where you've cut back a lot of tooth tissue. And therefore, the use of composite is not mutually exclusive. You may use it to trial out occlusal aesthetic changes, and you may use these sorts of restorations where you've kind of satisfied yourself that the patient is able to adapt to what you've done, but the patient or you want something more durable there without having to deal with the repairs needed for composite, and we'll discuss that in a minute. So what's the evidence base? Now, up to now, I've spoken a lot about composite, and unfortunately, the evidence for the treatment, the restorative treatment of tooth wear in terms of materials and techniques really relates to the use of direct resin composite. There are sporadic studies about using, palatal veneers, etc., metal veneers, but most of the available evidence relates to the use of composite. And the use of composite, and you've seen that obviously I favor that approach, and it's what's recommended in the consensus statement. It gives an aesthetic option. It's minimally invasive, well tolerated, can use it diagnostically, so on and so forth. However, it does rely on a good level of operator skill and the presence of a good quantity and quality of enamel. So let's have a glance at some of these studies. And there are about 15 of these studies published to date. And I've picked out a few because a majority of these studies are short-term, sort of 3-year performance data with relatively small sample sizes. But I picked out a few which I thought were interesting. Study done by Milosevic and Burnside. Sample had over 1,000 restorations It's an 8-year prospective study, and if memory serves correct, with an observation time of about 3 or 4 years, mean observation time. And they reported an overall failure rate of 7%. And it just as a layperson, I would think 7% for 1,000 restorations sounds pretty good. Study done by my colleague at King's, David Bartlett, they looked at 251 restorations placed over a period of 4 years, which were monitored, I think, observed for a period of about 11 to 12 months. And they reported a good success rate of 83%, bearing in mind that short term, but signs of chipping or fracture were seen in 63% of the patients included, with at least one or more failure. And the message to take home here is the first study that the clinicians were experienced consultants. The second study, treatment was provided by postgraduate students. And the message here is, or one of the things, two of the things that were highlighted is the importance of operator skill, especially with doing these composite buildups, as well as the influence of the etiology of the wear present. Study done by the Eastman group, Ghulam Ali and colleagues, and I've picked out this study because it's one which is looking at the DAL approach. And they had a sample of 283 restorations placed in superocclusion with a 10-year follow-up with a mean follow time of 5.8 years. And again, they found 90% signs of major and minor failure, typically wear, marginal discoloration, so on and so forth. What was interesting was the survival rate of replaced restorations was slightly lower. And the thought was that this might be amongst those teeth where there's less enamel available and a greater reliance on dentine bonding. And we know, despite advances with dentine bonding, enamel bonding is obviously gold standard and far more predictable. They also had some indirect restorations, indirect composites, and there wasn't that much difference. But what they did note was high levels of success with class 3 incisor relationships compared to class 1 or class 2 div 2. And that would be logical that if you look at class 2 div 2, you're going to do composite buildups on the anterior teeth. Those are likely to be exposed to quite high levels of tensile shear strains, and that may account for sort of a higher failure rate. So looking at the occlusion beforehand is very, very, very important. And again, you need to discuss these risks with your patients and how that can be managed. The fourth study, and I say this with an air of caution, is in my opinion, the most relevant one, not because I'm the author of it, but this was published a couple of months ago in the Journal of Dentistry, and I've highlighted some bits of the abstract, which I think warrant some discussion. This study included the largest number of direct restorations, direct composite restorations, or 1,269, with the longest observation period with any other study of 62.4 months, up to 5.5 years. And what we found is that the number of catastrophic failures where the restoration just couldn't be repaired was very small, only amongst 2.3 of the entire sample. The other failures were amenable to repair, where you could repair the composite by doing a bit of revision bonding or a bit of polishing. And what we reported were overall annual failure rates of the anterior dentition of 2.2% per year, and of the posterior restorations of 2.9% per year. Effectively, the posterior restorations are more likely to display signs of failure, but these are more likely to be of the variety where they can still be repaired to give service. And what we found, that the risks of failure at the molar teeth was twice as high at the premolars, and that would make sense given the higher levels of loading, as I discussed before. What we also found in a follow-up study, and I haven't included this here, which was also published in the Journal of Dentistry in July of this year, is that there's a significant association with how tall you make the restorations, how high you make them, with the survival. Essentially, the thicker, the taller you make them, the better they survive, and that would probably relate to the increase in sort of the compressional strength that you get with a material such as composite as you make it thicker. And the take-home message is, when you're going to put these, you do need to apply as much material as possible, respecting the sort of biological, aesthetic, functional parameters. Of course, you don't want restorations which look unsightly or with massive overhangs. But composite can offer a very good outcome if you got good patient selection and appropriate operator skill. And in this particular study, all 5 operators were skilled with adhesive dentistry protocols. So when you're looking to prescribe these restorations to patients, composite, you have to give your patients a proper discussion that these materials do require a lot of maintenance, debonding, chipping, fracture, wear and tear, discoloration will happen, and that's to be expected. And to try and help manage that, these patients will require routine monitoring and routine maintenance. And going back to the occlusion, one of the things that I focus on quite a bit is ensuring that that canine guidance stays in place, which helps to protect the other restorations. And I ensure that the patients are seen on a periodic basis. And if there's any early signs of wear, especially at those canines, which are taking the bulk of the hits, that's adequately managed. I haven't spoken much about crowns or ceramics, and to be honest with you, there's very little evidence available. There is a study which was published by Milosevic, again 6-7 years ago. They looked at the performance of 161 zirconia crowns for the treatment of severe anterior tooth wear, with a failure rate of 15.5%, with a mean follow-up period of 72 months. Failures were largely due to debonds or minor delamination chips, so on and so forth. And there were some factors where there were higher risks of failure, such as edge-to-edge relationships. But what we do know with crowns, for the limited data that we have for wear studies, is that crowns do perform better in the short to medium terms, in terms of minor failures, than composite does. However, when crowns fail, the failure is usually catastrophic, and that was shown in a study done by Smells many years back. And when it's catastrophic, it's often the tooth has gone non-vital, or the core is fractured, leaving you with a root stump. Essentially, the tooth has reached the end of the line. Now, if we go back to where the lecture started, we're seeing more and more wear and tear with younger patients. And we need to think very carefully about how we manage them, especially with going in with highly invasive treatment protocols. We don't have, as I said, we don't have extensive data on the performance of crowns for tooth wear, but taking a more sort of a global snapshot, study done by UK colleague Trevor Burke, they looked at restoration survival, and there were they looked at data for 3 million crowns placed on 1.2 million patients and 3 million resin composite restorations. Now, these are not exclusively on wear patients. I need to stress that. What they found was the time to next intervention for the crowns. 52% survived at 15 years, but with the fewest number of interventions. But when they failed badly. In contrast with composite, well, the survival rates were a lot less, with the need for a lot more interventions, but 83% of those teeth restored with composite survive without the need for extraction. So in conclusion, when you see a patient where it's really important to ensure you go through the processes, the prevention, the monitoring, and if you're going to restoratively manage these cases, where possible, the emphasis would be to take a minimally invasive approach, which gives you the opportunity to make some adjustments, to try and achieve the occlusal aesthetic endpoint, which the patient is satisfied with. And you can use more durable materials once you reach that stage by using techniques to predictably copy those sort of occlusal aesthetic features, using ceramics, using alloys, et cetera, So I think that's probably it from me. I thank you very much for taking the time for your attention and listening to my presentation.
Thank you very much, Shamir. I'm aware that we're a little bit running over at the moment. So what I've asked is that people can email Knightsbridge Academy with any questions for you, and they will facilitate them if that's okay.
That's fine. Thank you.
Thank you very much for your time. I'm pleased to introduce Dr. Mustafa Kamal Yunsal next, Born in 1965, he had his whole education, including dentistry, in Ankara, Turkey. In October 94, he was been awarded his PhD with the topic, the clinical measurement of stress and strain induced in Brannemark implant fixtures and abutments during the fitting of a cast beam and during application of simulated functional loads. He has been granted an associate professor in 1999 and a professor in 2005. He is still teaching and practicing as a part-time professor at the University of Ankara, Faculty of Dentistry, Department of Fixed and Removable Prosthetics. He also works in his private clinic in Ankara, Turkey, where he is mainly concentrated on dental implants and metal-free ceramic treatment options. He has been involved with education and teaching organizations for the last 20 years of his career. He has been lecturing to dentists, dental technicians, and dental assistants frequently in an attempt to keep up to date with their professions. Professor Ünsal is an active member of the European Association for Osseointegration, OSSEDA, and EDAD, which is the Turkish Association of Aesthetic Dentistry. Since June of 2012, he has been the founding president of TFI, which is Together for Implantology, a dental implant platform. His lecture is on tips and tricks that some of us don't know in fixed restoration impressions.
Thank you very much, Andrew. It was a very nice introduction. I would like to thank Knightsbridge Academy to give me this opportunity to be with you and with my colleagues again. I just want to ask, as usual, can you see it or hear me? Any problems with it?
We can see and hear everything. Thank you.
Okay, this is the tips and tricks type. Now, I know dentistry is going a long way, but now what we have to do is to concentrate on what is the basic of dentistry. Now, I hope it was a nice one. Our aim is to take an accurate impression. Now, what we do, we take impressions all over in our life. Dentistry needs to take the impressions. You can take it digitally now, but the traditional impression taking has some rules, and most of the world is still doing traditional impression. So we have to know what we are looking for. Now, doing in impressions, what we are looking is to take the impression of not the prepared tooth, but the neighboring tooth as well. And we are looking for a discrepancy of 50 microns. Now, when we say 50 microns, it just say, well, 50 microns, but I want to show it with some examples. Now, this is a ruler, of European style, not a British ruler. And each space in between these black lines is 1 millimeter. And what we are opting is 50 microns. So what we say, the classical books say that you'll make an impression and prepare and produce a final crown or bridge, and then you'll have a discrepancy of 50 microns. Now, 50 microns is quite small. Now I can show it to you. It's the same ruler. It's a little bit exaggerated in the next picture. And you see the space between two black lines is 1000 microns. And you are looking for 50 microns of sensitivity. So if you don't understand it, let's put it in this way. A human hair is 50 to 70 microns. I mean, one human hair is 50 or 70 microns. And you are looking for an acceptable gap of a hair. The thickness of a hair is your acceptable limit for a crown. So how can you do it? You need to take a good impression. That's the basics of it. Now, what are we doing? We are talking about everything, but we are not talking about the criteria for a perfect impression. What's it? Now, you have to do not only the prepared tooth, but its finishing line, borders, and the neighboring tooth has to be perfect in details. You have to take a clear and detailed impression of the opposing jaw as well, because you are making a restoration which should not be high, which should not be out of occlusion. So you need a good impression of the upper arc as well. And you don't need any voids or extra plaster in your model. So what you have to do is the exact presentation of the mouth. Now, there are some proved facts. These are all scientific. And let's go on them. 40 to 50% of the impressions are not satisfactory to produce acceptable restorations. I mean, we are making impressions all the time, but keep in mind that 50% of them actually are not acceptable to produce a 50 microns of fitting. So, and this is proved with 3 different studies. And 13% of them, 13% of them is rejected as there was no possibility to work with them. Now, that's a real problem because you spend some time, you spend some material, you spend some money, and then the technician just calls you and says, well, I cannot work on this. So impression has to be done. Now, having said that, I'm coming to some material aspects. I want to just go on the classification of fixed restoration impression materials. The first generation of them was polysulfides, which we don't use it anymore. So I'm not using any, spending any time on that. We are having C-type silicones, polyethers, and vinyl polysiloxanes, or in other words, acilicones. Now, let's start with C-type impression materials. Some of the examples are here. I mean, these are the brands that is used mainly. Most of the time we are taking impression with this type of materials, especially when the cost of them is important. We prefer C-type silicones because they are cheaper than the others. They are obviously much better than alginate impressions. However, they may lose their dimensional stability as short as 60 minutes. So you have a working time of nearly 4 hours. Now, I said 60 minutes before, but 60 minutes is the shortest time that you can use them. But in real life, you can use these impressions for 4 hours. I mean, you can pour the model of following the 4 hour that you take the impression. The main reason of this short working time is the alcohol evaporating from the material's body. And then we have polyethers. Polyethers are coming with different styles. I mean, not different styles, but different mixing styles. You can mix them by hand, or you can mix them with impression guns and special machines. Now, polyethers only produced by 3M because they have the patent of this, and they are the only producer of polyethers. Now, there are some disadvantages with polyethers and advantages. I'll go through them and we'll talk about them together. They are difficult in hand mixing. And they are very rigid. So because of their rigidity, it's very difficult to take them, to remove them from the undercuts if you have a mouth with many undercuts. And you must be careful because these are not always compatible with some synthetic plasters. So the technician, if he's not used to work with that, may use a synthetic plaster and then phone you and say, well, Doc, I'm sorry, but I cannot remove the plaster from the impression. So this is because some of the plaster materials are not compatible with polyethers. They are potentially allergenic, and obviously they are expensive. But they have some huge advantages. They have high tear resistance, which they do not tear very easily. They are hydrophilic in their nature. Their dimensional stability is the best of all the impression materials. Because of this, you can use the same impression to produce more than one set of models. And in a dark and non-humid environment, you can keep the impression as well as sending your impressions to another city, if your laboratory is in another city, is very suitable to use polyethers. And now we came to polyvinyl siloxane. There are different brands. I mean, all the impression companies, impression material companies produce A-type silicones, and they are very handy. They come with a flowable one, and they have a putty. You use the flowable silicone in the mouth, and at the same time, your assistant prepares the putty, and then you put it in the mouth and take the impression. It's quite easy, but they also have some advantages and disadvantages. Not all of the brands show the same hydrophilic character. I mean, A-type silicones are not hydrophilic in their nature. Because of that, all companies put some other chemical agents to make them more hydrophilic. They are incompatible with latex gloves. If your assistant is using some latex gloves, she will not be able to mix it with the gloves. Dimensional stability is between C-type silicones and polyethers. They are hydrophobic in its nature, I have already told that. But they have some advantages as well. High elasticity to resist tearing, good detail capturing, reasonable waiting time on the bench, and no toxicity or allergenicity. And now this was the basics about the impression materials, but I want to tell something about the importance of tray adhesives. We do not think that they are important, but they are very important. Let's see. Tray adhesives are chemical agents that we apply on the trays so that the impression material holds better in the tray. Unfortunately, we have to use different materials, different bonding agents for every different impression material. Polyethers has different adhesives, alginate has a different one, and A-type silicone has a different one. Although there are some universal bonding agents, specific bonding agents are much better than the universal ones. Now, why do you have to use it? We have to use it not just to retain the impression material, but to overcome the shrinkage of the impression material. If you apply the bonding agent to the tray, then when the impression sets, it will not be able to contract, so your impression will be safe and correct. But if you don't apply it, there's a minimum chance of contraction within the silicone. So if the silicone contracts, you will have a gap in between the tray, and more than this, your impression may be a little bit, how to say, shrink. So you have to use impression tray adhesive. So let's look at the impression trays. Which tray should we use? There are many trays in the market. This type of perforated trays, like this one, some plastic ones, some disposable ones, and the bite impression trays. Now, I always prefer this type of perforated tray with a rim on it. The rim is here because it just produces more retention to the impression material. However, I don't know the other side of the world, but in Turkey, we have this kind of trays, which I do not like very much because they are not very standard in size. They have small holes and they don't have any rims around them. Okay, so the other question is whether to use a perforated tray or a closed tray. The purpose of perforation is threefold: reducing the pressure during the impression, firm retention of the impression material, and rims and to increase the retention of the impression material. So if you use this type of perforated tray, it will be much easier to retain the impression material on the tray. But the disadvantage of this, if you are using a flowable type impression material, it's very difficult to take it with them because it's perforated, and all the impression material will flow from the perforations. So therefore, you have to choose a closed tray, and in this case, you have to use a tray adhesive with the impression material. And there are some much more different tray types, perforated ones, small ones, only a partial one. I use all of them, but I use this bite tray, especially the semi-bite tray. I don't like them very much because it's very easy to deform the tray. And I will show you some examples with the other slides. Now, the main thing with the tray selection is your tray have to be rigid, satisfactorily rigid, because if the tray is not rigid, your impression will change. So you have to use a tray which is very rigid for your purpose. So a flexible mobile phone is good, but a flexible tray is not a good thing. So how long do you need following the preparation for a good impression? Well, the main thing with taking the impression, I mean, we are fighting with blood and circular flow, because the circular flow and blood, which are both liquids, they just don't allow your impression material to get into the sulcus. So what you have to do is to stop bleeding or circular fluid flow prior to impression making. So this question depends on how you work on it. I mean, if you don't apply any special agents to stop bleeding, then you have to wait at least 3 minutes before making the impression so that the bleeding does stop. Increased washing of the mouth by the patient makes bleeding more. So it's difficult to take the impression if your patient washes his or her mouth too much. Just going on deep on that, I just want to talk about bite impressions, and then I will talk about circular fluid as well. Now, bite impressions has a potential hazard for all of us, because when you ask patients to bite something, they don't know what to do or what to expect. So you just put the impression material in both surfaces of the tray and ask the patient to bite it. But because the patient doesn't have any clue what to do, he just bites on it. And although he feels that he's chewing the tray, he doesn't aware how important it is. So when you make an impression, and if the patient bites on the side of the tray, the edge of the tray, the patient will realize it, but will not understand what it is. So when you remove the impression, if you see that the patient has bit the tray, then you have to repeat the impression, because this will always come to you as a high crown or high restoration. And also there's a tendency in people, if you put something in not in both sides, but in one side of the mouth, they tend to move their jaw to that side. So you have to check it correctly. If you are using a semi-impression tray, you have to check you have to check it with caution, so that he will not bite in a position that he doesn't have to do. So when can you use the segmented trays? I only use segmented trays if I'm doing a single crown restoration. If the restoration is more than a single crown, I always take the impression of the full jaws, upper and lower together. Now, let's come back to soft tissue retraction. Now we have some methods of soft tissue retraction. The first of them is to use a cautery machine or use a laser to stop bleeding. The other one is to pack a cord into the sulcus. And the third one, and something which is gaining popularity, is the pastes that we can use to extend the sulcus. Now, when you pack the cords, there's the likelihood that you can damage the tissue. So what you have to do, don't use the maximum thickness cord. If it's a young patient without any periodontal problems, the tiniest cord will be enough for you. And you have to insert it with a gentle pressure. Too much pressure will also damage the gum as well. And there are special tools for packing the cords. So you can use them and it will be enormous help for everyone. I like to use pastes in the last 5 or 6 years. They are very handy. They stop bleeding as well. And they are much easier than using a retraction cord. So how to apply them? They have a very tiny tip. You have to insert the tip between the preparation and the gum, and you steadily press the gum to extend some material into the sulcus. Obviously, this is not enough. If you ask the patient to bite a cotton roll on top of it, or you press it with your finger pressure, then when you wash and remove the paste, you'll have a nice retraction all over and you'll not have any bleeding at all. Now, obviously, there are some other bleeding management agents. Most of them contains ferric sulfate, some aluminum preps, and astringent are all in that category. What I don't like with ferric sulfate is it's very, if you put it on somewhere, it stains everything. That's one difficulty. The other one is when you put it in the mouth, it stops bleeding, but the blood clot stays in place. And that blood clot does not allow you to take a good impression. So you just wash it to remove the clot. But when you wash it, then you start having a bleeding again. So my preference in the last years is to use pastes instead of some ferric sulfate or aluminum solutions. There are 2 types of retraction cords. One of them is braided, the other one is knitted. I prefer the knitted one because it's very easy to pack into the sulcus than the braided ones. This is a retraction cord of knitted one. You just see the knits between the lines, and then you just pack it very easily if you need it. There's one method which is advocated by many books, but I'm not very, personally, I'm not very successful on using that method, although I will tell it to you. Now, these suggest that you can put the flowable impression material around the sulcus and apply some air pressure with the air syringe. Now, this method is very logical, but when I tried to do it, I always ended up with air bubbles within the sulcus. So I'm not using that. If I'm making a good retraction, I just put the flowable impression material around the teeth, that's all. I don't spray any air. Now, what's the ideal impression? What are we after? We are after a very good finishing line reproduction. So the impression material here representing a good impression because it just shows you your finishing line and then the gap around it. So your technician can produce a very nice fitting crown on that impression. I just want to share with you how the problems get on with our impressions. Now, if you see something like that, you know, the impression material is not very complete on the edges. There are 6 causes of it: improper retraction, insufficient removal of blood or cervical fluid, insufficient drying, impression making close to polymerization. I mean, you put the impression material, but it was just polymerizing, and then you just pressed it on the with the tray. So that produces something like this. Your impression material's tear resistance may not be as good, and the improper application or too little silicone, which is not enough to flow on the sulcus, are all the causes of this type of impression. If you have air bubbles, just as I said before, it may be because you use the air syringe. You could have left some blood or saliva here. You may be storing your silicone at a high temperature, but you shouldn't put the impression material in the fridge. The impression materials, all of them, has to be stored at room temperature. And you may also put the tray in a false position, wrong position. If you have a tearing at preparation margins, you may have insufficient retraction. Bleeding stopper chemicals, some of them are not compatible with the silicone that you are using, and they just retard the setting of the silicone. So if you don't know this and check the setting time by touching the impression material around the tray will be set, and you say, well, it's set, I can remove it. But because of the bleeding stopper agent, your silicone within the sulcus is not polymerized. So you end up with such kind of unsatisfactory impressions. You may have some temporary cement remnants in the sulcus. You just remove the tray too early. You may not be able to mix it properly, or your silicone may reach its expiry date. And if you see impression tray visible within the impression, it's the first thing that you suspect is the improper tray selection. Errors in tray positioning, too much pressure you exerted on the tray. You may not be putting the constant pressure on the tray, and the impression material may be less than what has to be there. And if you see flowable silicone lacking, then it means you didn't put enough silicone around the teeth. But the most of the time, the main problem is the putty that you are using is too hard. So when you press the putty, all the silicone material, I mean the flowable silicone, just runs out, and you are left out without a detailed impression of the sulcus. And if you have a lack of polymerization, it means you couldn't mix it properly, and your expiry date may be ended as well. Also, intraoral immediate temporary materials. You know, we use immediate impression material, immediate temporary materials for tooth preparations, and they have some kind of oily bis-GMA in them. And if it stays on the tooth, then when you take the impression following the temporary making, you'll end up with a impression like this one. If you remove the tray early, and if you store your silicone in the fridge, you may end up with an improper polymerization. Removing the tray is also important. How to remove the tray? It has to, I mean, not all teeth are same. In some patients, you have some teeth which is in awkward positions. So if you have a very angulated teeth, what you have to do is to remove the non-angulated side first and then remove the angulated side. Because if you do it other way around, then you will be forcing the impression material to leave the tray. And not only that, you will also damage the impression as well. So what you have to do to remove the normal angulated side first and then the too much angulated side. Digital impressions are another story. I'm not covering that in my speech this time. And I would like all of you, thanking all of you for watching me. Thanks. I can take any questions if you have any. I'm with you. I don't know if I have, I'm okay with the time. But I'm waiting what you would suggest, Andrew.
You can take some questions, that's fine.
Yes.
If anybody has any questions, they can put them in the Q&A on the Zoom meeting if they want.
I think they have to put it on the chat, don't they?
Yeah,
They-
okay. Or the chat.
Yeah.
No, you must have answered everybody's questions, I think.
Hopefully, hopefully.
Always good. So thank you very much for your time. We have a little 10-minute break now until the next professor, but thank you very much, Dr. Mustafa. That was great.
Thank you, Andrew.
So 10 minutes until the next one, people. Thank you very much.
Thank you. Bye-bye.
Hello, Andrew. Can you hear me?
I can hear you, Dr. Chan.
Okay, shall I start up now? Let's see whether I can see my screen now. Can you
Great.
see my screen, Andrew?
We can see your screen. Thank you
Excellent.
very much. So I will introduce you.
Yeah,
I'm pleased to introduce Professor Wyman Chan. Dr. Wyman Chan, BDS PhD, is a dedicated clinical teeth whitening and research dentist practicing in London. For over 20 years, he has worked with all major home and power whitening systems. His PhD in efficacy and safe teeth whitening processes led to 7 UK and US patents. Dr. Wyman Chan has discovered the important phenomena in the texture of teeth and establishing protocols that have contributed to the movement in safety and efficacy of tooth whitening processes. He published important hypotheses in tooth whitening processes which help evaluate the texture of tooth enamel. Dr. Wyman Chan is well credited as the inventor of painless tooth whitening techniques and products. He was appointed as a clinic associate teacher at Warwick Dentistry, the University of Warwick from 2010 to 2016. He peer reviews for the British Dental Journal and has contributed to a book, The Art of Treatment Planning, Dental and Medical Approaches to the Face and Smile. That was Quintessence Publishing, October 2010. Dr. Wyman Chan's expertise in the field of teeth whitening in London is unparalleled, having treated over 16,000 cases in his London teeth whitening clinic and trained over 10,000 dentists from all over the world. Dr. Chan has appeared on BBC's The One Show, The Truth About Your Teeth, Fake Britain, Radio 5 Live, and Sky Living. The lecture today is The Important Role of Teeth Whitening in Aesthetic Dentistry. Thank you, Dr. Chan.
Thank you. Okay, thank you. Good afternoon, everyone. The time zone is different. Yes, I'm really honored and delighted to share some of the insights of teeth whitening with my colleagues. I graduated from Guy's dental hospital many years ago, and I did my PhD at Bolton University, which is the efficacy and safety of teeth whitening processes. I think have been introduced. I have many more patents since Andrew introduced. I have 14 patents been granted now, and as I said, train many dentists all over the world. I'm an inventor as well. I'm the founder of Perfect Trays, which is amazing bleaching trays and also whiten teeth whitening products. So in my own clinic, I only use my invention. So these are some of my inventions. And year 2002, that is a landmark for me, because that year I opened a dedicated teeth whitening clinic in central London in the West End at Shaftesbury Avenue. At the same time, I decided to hang up my drills. So I stopped becoming a normal dentist 19 years ago. I just dedicate myself to do teeth whitening. That's what I do all day long. Every day, apart from teeth whitening and in the clinic, I do research as well in the lab. So to date, I've done over 20,000 teeth whitening procedures. I think today we talk about aesthetic dentistry. So how do we improve the aesthetic of these teeth? This is a very, very typical baseline color with somebody never had any aesthetic treatment done but before. The color of the canine is about B3. Usually is many shades darker than the anterior teeth, than the centrals and the laterals. This is very, very normal. Canine teeth are usually many shades darker. I think we dentists notice that all the time. And also that was the simple teeth, that's yellow teeth. How do we improve the aesthetic of these teeth? With severe fluorosis on the left side and severe tetracycline stains on the right side. So how do we make these teeth look nicer? But firstly, let's look at what is an ideal dentition. We always talk about an ideal dentition. It got to be functional. It has to be able to eat and bite and chew properly. It got to be healthy. The teeth got to be healthy. Not only the teeth, the surrounding tissues and the supporting tissues got to be healthy as well. And when we talk about aesthetic dentistry, then we talk about they have to look nice and beautiful. They must aesthetically pleasing. This is an ideal dentition. But how many of us have this? Really not many. The percentage is very, very low for anyone to have an ideal dentition. Okay, so and that's why we do elective aesthetic dentistry to make the teeth look better without compromising the health of the teeth and the surrounding tissues, and also without compromising the functional effect of the capability of the teeth as well. So what are the treatment they are? We could align the teeth if they are not straight, if they are crowded. So the most common is align the teeth. And also we change the tooth or the teeth shape. If it do not look good, we change shape as well. This is the aesthetic dentistry. Also, we change the color as well. If the color is not bright enough or not too white, and then we change the color. This is the traditional aesthetic cosmetic dentistry. That's what we do. So, what are the methods of achieving alignment? Align the teeth and change the shape of the teeth and also change the color. So we have in tools, we have a lot of things we can do. We can do restorative dentistry. So we can align the teeth with restorative. We can do all three. You can align the teeth if they are not too crowded. You can change the shape of the tooth as well, and then you can change the shade as well. And what do we do with that? So with a minimal invasive technique, we can use composite veneer. So provided we do not compromise the health of the surrounding tissue, I think this looks pretty good. We can use porcelain veneers as well, minimal invasive, or we can go for the more invasive technique, which are porcelain crowns. The crowns here looks really nice. And what other method can we do to do aesthetic dentistry? We can use orthodontic method, but orthodontic is limited. We can align teeth, We can change the shape of the tooth by intruding and then extruding the teeth. We can change the shape of the teeth. But with orthodontic treatments, we cannot change the color of the teeth. Yes, some of the colors may become like white patches, but that was not intentional. So basically, we can do 2 out of 3. And chemically as well, we can change the teeth, make it look nicer chemically. Chemical means, what do we mean by that? We can do teeth whitening. Teeth whitening is limited as well. Only can change the shade of the teeth. We can make the teeth brighter, whiter, but we cannot align the teeth. If they are crowded, we cannot change that. We cannot align the teeth. If the tooth shape is not an ideal shape or what a good shape we want to change, we cannot change that as well. So teeth whitening is only limited to changing the color of the teeth. So what is teeth whitening? Teeth whitening represents a bleaching process that removes stains and enamel in the dentin, in the enamel and dentin of the teeth. So the active ingredients of is hydrogen peroxide or carbamide peroxide, which is commonly used by the dental profession. So, and there are many ways of doing teeth whitening. These are the most popular ways. There are many other ways. You have in-office bleaching, you have home bleaching or whitening, you have internal bleaching, and you can do the combination of the above 3 together. You can do it in any sequence you want. So there are many ways of doing teeth whitening. I think a lot of you probably have done teeth whitening, and many of you may be very experienced. I think if you do some teeth whitening, or you've been using a certain way, if it works in your hand, I advise you to do not change. Stick to something that really works. But if you think that you're not happy with the result you have, you think that you want to do better, you can always consult me. I'm more than happy to help. And hopefully you can learn a lot from this webinar. So what is in-office bleaching? In-office bleaching, in fact, is something we do in a clinic. Normally, we're using a more concentrated gel, peroxide gel. You can buy up to 40% hydrogen peroxide within the profession. But if you are from the EU, we are limited to only up to 6%. It doesn't matter what we use. And it depends on the system you use as well. Some system they use isolation dam, and some do not. It depends on what you use. If a concentration is very high, obviously they will use something to protect the gums. If the concentration is low, like in UK, only 6%, maybe we don't bother because it's so weak. And there are also many different types of teeth whitening devices. This is a good time to go back to, I think history is important. We would look at how in-office whitening was started. In fact, it was started many years ago, over 100 years ago. But when it became modernized, when it became using a machine, that is when in the 70s, a company called Union Broach in the US actually invented a bleaching a device. They are using heat. So in those days, the first really talk about advanced machine in those days are using heat, and they are using hydrogen peroxide liquid. In those days, it's not gel as well. And then we move on to 1997. That's when I got excited about teeth whitening, because I was introduced to creative using a plasma light. It's a curing light. You can use it as a curing light as well as a bleaching light. So really excited, and we're one of the pioneer dentists who started this. I got even more excited in 1999 when this happened. Bright Smile actually brought in the first bleaching lamp. I think this is an amazing invention. This is the first time we dentists do not have to put our fingers into the patient's mouth and then we can make a living. Then we paint a gel, we put a machine, and the machine is 3 times 20 minutes initially. So it's an hour, we don't have to do anything and we get income. I thought this is an amazing. I got really excited about this technology in those days and started researching into this and doing a lot. And then this is my invention in 2007. I actually went back to heat, from heat to plasma to laser, blue light. I went back to heat. All these are heating devices. This is the high power, the Y10, and this is my latest, Dr. Kwame Chan. We call it the Get to Smile device. Professional home whitening, it was started in 1989 when Haywood and Heyman published a night guard vital bleaching at the Quintessence in March 1989. This is when everybody got excited about teeth whitening, because this is the first time we have proved that carbamide peroxide, they're using 10% carbamide peroxide in a mouth guard, and then actually make the teeth whiter. But before that, in 1968, an orthodontist by the name of Krusmir already doing it, and he's been lecturing in his study clubs. And that was until 20 years later that Haywood and Heyman and knew about this, and then they actually went about and proved that the 10% carbamide peroxide actually do whiten teeth, that does whiten teeth. And most dentists think that teeth whitening is very similar, very simple. I used to think the same. In the 1990s, when I started doing home whitening, I thought it was quite simple, really simple. What I had to do is take a set of alginate impressions, send to the lab, get my bleaching trays done, and get my patient some gel, and keep my fingers crossed, and hopefully the teeth will go white. That's what we used to do. I'm sure lots of us still doing the same thing. And so home whitening, that's what it is. Let's use some peroxide gel with some bleaching trays. There are so many different systems in the market. And in office, what is an office? So dentist thing is very simple as well. It's the use of peroxide gel, but this time it depends on the concentration that we use. If we use very high concentration, like the commonly used internationally, is about 35% hydrogen peroxide, and that is very caustic. We should use protection to protect the gums. And dentists say that it looks very similar. All the systems look very, very, very similar. So what are the indications of teeth whitening treatment? As long as the teeth are natural teeth, it will work. It doesn't matter what they are. It doesn't work on artificial teeth like crowns, veneers, dentures. They don't work. And fillings, they don't work. So let's look at the problems and risks associated with teeth whitening. I think the most common we see is inconsistent and unpredictable result. That yes, we do teeth whitening. We always keep our finger crossed and just hope for the best that will produce result for us, and the patient's happy, and then we feel comfortable. The second problem is the result. Yeah, we do have results. I'm talking about especially in the in-office whitening. Yes, we have result. At least 80–90%, we see very good, not just result, very good results. The problem is that they don't last long. They fade back rapidly. That is a problem. That result, but did not last long. And also we have problem with sensitivity as well and pain. So that's why many systems, they actually they advocate the use of analgesics or desensitizing agents before or after treatment. So ibuprofen is very common. I used to use that when I was started doing teeth whitening over 20 years ago. I wasn't experienced. Now I hardly use any of these products. Yes, I used to use potassium nitrate as well. I'll put it in the whitening trays if I have sensitivity. But now the more experienced you are, and then you don't have to use this kind of materials anymore when they become really experienced. But when they're not experienced, I think it's helpful so that your patient will feel comfortable. The loss of shininess on the teeth surface, and this happens especially when you do in-office whitening as well. And also, I think the fifth one is very troublesome. Damage to the gingival and or soft tissue. Now, this is actually published 13 years ago in an Australian dental practice and in a journal. The use of the 35% hydrogen peroxide in office, they found that this is what is read. The white area on the gingiva are caused by the irritant effect of radicals from the bleaching gel that have leaked onto the tissues during the procedure. I will raise my hand up. This happened to me before, not once, many times when I was inexperienced because the dam wasn't put on properly, it wasn't stuck on properly. It can happen. If you're not experienced, it can happen. So then that's why these dentists are very modest and actually put it in the article and warn the fellow professionals that this can happen, and please be more careful and do the protection, the isolation better. So I'm sure it happened to everyone, whoever has done in office, must happen to everyone. If it happens to me, it can happen to anyone. But this is more severe. When it's not done properly, you got a very severe burn. This is the loss of tissue. Obviously, this doesn't happen to me, but it is very serious. Also using 35% hydrogen peroxide. And this is at the exhibition. I see that all the time. I go around the world and people using 40% hydrogen peroxide. I think the protection is not enough, and the lips got burned. So it's very common. You see this. Is if this can happen to a teacher who is doing a demonstration at the exhibition, supposed to be a very experienced dentist, and what hope is there for the rest of us? So it can happen. So don't feel so sorry if this happen. But we can prevent all these. What I show you is preventable. All can be prevented. And fortunately, this wasn't done by a dentist. They actually were done in Scotland, in the UK. And this happened actually in hairdresser. A hairdresser doing teeth whitening. It was very popular in the UK. A lot of non-dentists were doing teeth whitening and using very high concentration, using 35% hydrogen peroxide. And the patient actually done by her friend, a hairdresser, and she posted onto the website and asked people to not go to the non-dental or professional. What happened is that the gel leaked to the soft tissues and the lips got inflamed, and that's why the lips become so swollen. This is 24 hours after. So if all this can be prevented, all I want to show you, all can be prevented. All this now, if you do it carefully and do the SOP properly, all this can be prevented. And many of my colleagues ask me, what method do you like to do? I like to do combinations. I like to do in-office, and then I like to do home bleaching. Sometimes I do in-office first, followed by home bleaching. And sometimes I do the home bleaching, followed by in-office, and followed by home bleaching. So there are different ways of doing teeth whitening. I think what works in your hand is most important. If you get good results from certain method, just continue with it. Unless you think that some other method can get you better result, then you always can try. You always can try. There's so many different ways of doing teeth whitening. The standard operating procedure, just go through what I do when I do teeth whitening. Photos are very important. I normally take 4 photos. What I do, I take a photo using a shade guide, which is the Vita classical guide, and from the B1 to the C4. So this is, I usually put a tag opposite the centrals. So this is as a guide. I'm not doing a shade taking here. This is only a guide of the color. I realized after I've done so many cases that 80% of the centrals are usually A2 if they haven't had any aesthetic work done before, and 95% is fall within A1 and A3. If you use A2, you can't be followed. We're not taking shade. We just have a guide so that we know what color they are. And the laterals and the canine, 80% is A3.5 B4, so you can't go wrong. And then it's about 95% between A3 to A4. If you use this shade guide from A1, A2, A3, A3.5, A4, you can't go wrong. So at least we will see a guide that gives us the what kind of color they are and how close they are to A3.5 and how close they are to A2, because no tooth is A2 color. So our teeth have many colors. And then I take a full mouth with all the gums I want to see, just in case the patient complains that, oh, you damaged my gum. At least you have that before photograph to show that, no, I haven't, because your gums look exactly the same as I did it before. And then I always take a portrait as well, so I can see before and after. Okay, in my clinic, I work 2 days in my clinic now. I cut down a lot. I used to work 3 days, 3.5. When to come to my clinic, I don't just do teeth whitening. I do aesthetic and dentistry. So I ask my patient to choose the color. I give them a shade guide. Normally, I give them up to B1, a normal Vita classical shade guide. If they say the B1, and some people they want the teeth to go really white. They ask, do you have anything whiter? Only then I take the OM 1, 2, 3 out. But normally most people are quite happy with B1. But at my clinic, 95% of my patients they want whiter than B1. So from a B1, from the data, I have the big data, the 20,000 cases I've done from B4 to B1. It's not difficult. If you use the right technique, use the right products, you can get it usually between 2 to 4 weeks. Yeah, it's quite predictable. So I always show them when you want a B1. So I take a B1 out from a shade tag and put it next to the B4. At least the patient can see the contrast between the B4 and B1. If he's B4 and then B1 is so far away, they have to look here and then look over here. And they find it difficult to comprehend how white the teeth have gone to. So we've got to put them side by side. Then they can see really, really clearly. Okay, so how do we improve the aesthetic of these teeth? This patient come in, quite young, it's only 21, and she say she only want to whiten her teeth. She's not consider any. I'm not worried about the mild crowding. Not worried about that at all. Only she doesn't like about the color, especially the canine. She says it's too dark. When she take photographs nowadays, the social media days, it show up with a good lighting. So she doesn't like all this color. Now, in old days, not that bad, but nowadays it show. A lot of my patients come in because they do a lot of selfies, they do a lot of videos, and they could see the teeth are yellow. So how do we do? We just do 2 weeks teeth whitening, and I think the result is pretty good. So from A1, B2, we gone to OM2, and then from a B3, you go to OM2, and then the worst one is OM3. So I think it's pretty good. And then we've used this is the crystal eye, the spectrophotometer, which you can tell me how many shades the teeth gone whiter, gone 18 shades whiter. And we can do from here, we can see the full mouth. That's why I always take a photo here with a B3, and then I'll always take the after photograph with the same shade tag, so that the patient can see the contrast. I know this gone to OM2, OM3. If you put an OM2, OM3, the two photos, they really do not look that impressive. If you put a B3 next to the whitened teeth, they look really, really impressive. So how do we improve the aesthetic of this dish? Joel is very young. When he came to see me in 2010, only 15 years old, and the mom came with the mom. Mom said, "I just want to." Joel is not happy with the color of his teeth. Just want to improve. So same, we did 2 weeks as well. I think the color was also amazing. From B3, also gone to OM3, OM2. I think the color we can produce this kind of result day in, day out, and it's 18. 19, about 18 shades whiter before and after the contrast. So people say that, oh, it's different color. Yes, because the setting is different, it's another time. But the most important is the contrast. People can see the contrast of that. So that is very close to B3, but that is so much wider than B3. And a 19-year-old did it 2 years ago. Really good, came in with an A2 color. When we finished, we've gone to an OM2, also 15, 16 shades whiter. And this is his sister. We did start with A2 as well. And then when we finished, it's gone nearly about OM1. So many, many shades whiter, 13, 14 shades whiter. So only 2 weeks. How do we also improve the aesthetic of these teeth? Yeah, we can see it's like crowding. Tom said that he only wants his teeth whitened, hasn't got money to do the rest of the work, to align the teeth, orthodontic treatment, all that, hasn't got enough money. So just want to do the first step, just have the teeth whitened first. And then from our spectrophotometers, we can analyze the teeth. We saw that the canine is A2, and the centrals and the laterals A1. So we just did one treatment, which is 2 weeks, and then it's pretty good results. From A2, gone to OM3. From A1, gone to OM2 or OM3, and the colors is nice and even, really nice and even. If you notice that, 2 weeks, I think that's a very good result. And Tom is very happy to show off his new smile. Emma, we did it in 2013. Also, just want to teeth whitening done. So we also did 2 weeks. We done hundreds, if not thousands of these cases, just to show you. Okay, those are really easy. The yellow teeth are really easy. Now look at some difficult cases. I'm very proud to show off some of the cases by my students, which is, this is Dr. Zhen from China, Wenzhou. And she's a qualified, we said a certified Dr. Wyman Chen, dentist. I do a lot of training in China, spend a lot of time there now. And this is a very interesting case. And this patient, Mr. Yu, 68 years old, and only don't know why he started to care about the aesthetic of his tooth. And he told Dr. Zhen that he had this tooth for 40 years now, since rootfield had an accident, rootfield trauma, and just lived with that tooth for 40 years. So maybe he decided that he wanted to make a tooth whiter, say he wished to change the tooth color to match the rest of the adjacent teeth. And that tooth can see C4 is so much darker than C4, so much grayer than C4. And I actually help Dr. Zhen. I do a lot of treatment planning now for dentists in China. That's what I do. We provide treatment planning, like Invisalign. That's what I do now. We're like Invisalign. The dentist send us the photos and send out a lot of work, X-rays, and then from then I ask them to do a few other some other work, and to analyze the teeth, so I can give them a very precise treatment plan and to the color that they want. So this is only traditional treatment. This is of choice. Is internal bleaching. What is internal bleaching? Just quickly go in there. We open a hole from the palatal side, because that has got a composite filling, and then we remove the GP points, the rootfield all the way down a few meters, 3 millimeters below the bone level, the crest level, and then we fill up with GI, and then we put hydrogen peroxide or sodium perborate or whatever you have in your hand, and then we seal the cavity. Also keep our finger crossed, and hopefully the teeth will go white. That's what we do. This is a treatment of choice. But we decided not to do that, because I haven't done internal bleaching for at least 9 years now. The last time I did probably about 2012. So we do a non-invasive. We don't even drill. So I advise her, I say, let's try this method, because it worked really well with me. So we're using a customized trays, and this is only 2 weeks. Review the patient. I was quite shocked. I didn't realize it worked so well. And because the patient only treated one tooth, and then when we put onto a mixing pad, there's some excessive gel, so the patient put a little bit next door, and then put a little bit on the canine, and this teeth got whiter as well. So I thought this is amazing result in 2 weeks with just external bleaching, no internal bleaching, no walking bleach, no inside outside. There's so many ways that the traditional way of doing it. This is purely non-invasive external bleaching with tray, with perfect tray. Okay, let's look at another interesting case, a traumatized tooth, a sound tooth. So what would you do if the tooth is not root-filled? You see that, you can tell. What are the treatment plan for Olivia? Olivia came to us when she was 18. Presented herself with a discolored tooth. She said she knocked a tooth 10 years ago when she was 8 years old and bumped into a wall, and only realized this about a year ago. The teeth started to get discolored, getting more and more discolored. Traditionally, we can do porcelain veneer on one tooth if the patient just want one tooth to be treated, or you can do porcelain crown just on one tooth. Depends on what you like to do. But in this case, I offer also traditionally we also can do internal bleaching. I've seen this. I actually seen this in articles that some of my colleagues they open up a hole, do a refilling, and do internal bleaching, and the result is very good. They actually match it to the color of the tooth next door. It's very good. But Olivia says she not only wants the tooth to match that, she wants the rest of the teeth to go white, including that, and including the front teeth to go white as well. So to do that, so we offer teeth whitening. So just 3 weeks. We have a system called Get Your Smile, which is a paint-on system. We use that. This is an amazing result we have. Just 3 weeks. Look at the dates: 16th of February and 9th of March, 2010. from A1 will go to OM2, from a B4 will go to OM3, the canines B4 will go to OM3. I thought that was amazing result. And non-invasive, we don't have to drill a hole, don't have to do a root filling, and do not have to put a restorative and palatal on that too, or non-invasive from here to here. I thought that's amazing. And we got it about 18 shades whiter. And she's very happy, Olivia. How about fluorosis? It depends which area you come from. If you come from an area the water not treated, you have fluorosis, for example, here. This is moderate, it's not severe. So the patient is not happy about the uneven shade with white patches because he's getting married. I want to take some nice photographs in Bali, in Indonesia, so that want to have the teeth whitened so that he can smile. Now he doesn't like to smile because of the color of the teeth. So there are many different ways that traditionally, a lot of dentists would have done, or would do microabrasion. So what is microabrasion? Microabrasion, for example, teeth like that, they may use strong acid. Traditionally, we use 18% hydrochloric acid, and nowadays we use 35% phosphoric acid with a bit of a pumice, make into a paste. And then you use a slow handpiece, you use a brush, and then to brush it in. And you can easily remove even 10% of the enamel if you're not careful. So this technique is very abrasive. So we've got to explain to our patient, microabrasion, enamel microabrasion actually is taking layers of enamel away. And it could be 10% of the enamel, can be a lot. So this is something we need to tell our patient, that microabrasion is taking enamel away. It's just like putting a burr on here and just drill away. I think that's faster using a burr rather than using this method. You should do that. Okay, you can use microabrasion with this technique, but David said doesn't like to lose any enamel because I've been waited for so long. I want something different. How about resin infiltration? Resin infiltration, that means we apply resin in this area, and then how do they change color? It's by the alteration of the refractive index, because this area much more porous than the normal. That's why they look the white patches here. So the resin infiltrate into this area and then just change the refractive index similar to the rest of the teeth. That's why the color looks similar. But this is making teeth yellower, not whiter. So David said, no, I want to make a teeth whiter. I don't want my teeth to look yellower. My white patches become yellow. So that's another option that David rejected. So I say now we have two other methods left. We can do both porcelain veneers or can do non-invasive teeth or whitening. And obviously, David been waited for so long, 38 years. So we say, I want to do the non-invasive way. Let's give it a go. So 4 weeks, we did that. I was really shocked when I saw David back in then, I think 2013. Not only the white patch is nice and even, I saw that there's quite a lot of remineralization as well. All these white patches disappear. So beautiful. So if you've got a system that can make a teeth white and also do some remineralization, isn't that wonderful? And David is very proudly showing off his new smile. Angel, 30 years old, quite severe. The fluorosis, you can see a lot of white patches there, very, very opaque. And then you've got very dark brown color there. And then you can see lots of pits as well. The enamel, actually, quite lots of lesions there. Same we can offer. I offer Angel the four standard treatment: microabrasion, resin infiltration, porcelain veneer. She rejected all of them, and she said she wanted a non-invasive treatment, which is a teeth whitening. So we did that 4 weeks as well. I thought that's a pretty good result, but I'm not happy with the result. But I told her that we need about 4 to 12 weeks to make it really beautiful. But Angel says she's so happy with her teeth that I could not ask her to spend more money to have more treatment. I think this look pretty good, but if it a bit more time, this can look even more amazing. But Angel was so happy with the treatment. You can see that all those not that obvious anymore. It's a lot of remineralization going on as well. Okay, let's look at tetracycline stained teeth. This is very severe, how would say, a lot of this in the Far East, because the Asians, especially the Oriental, the Chinese, and they like to take medications. So that's why they took a lot of medication. This is a 58 years old. Patrick came to see me with moderate tetracycline stained teeth from Hong Kong. Same thing of porcelain veneers. This is what we could do for a patient. We could do veneer, we can do crowns, we can do non-invasive teeth whitening. And Patrick said, I've been waiting for so long. I just do not want to. I want to see a dentist. So I want to improve the aesthetic, or the dentist say, no hope. The only hope is we have to do veneers or crowns. So he actually bumped into me in the exhibition in China. And then he started asking me about whether I can do anything about his teeth. And then I said, yes, you come to London and see me, and then I will do something. And then 6 weeks later, he came over to see me all the way from Hong Kong, and I'm very happy. So 6 weeks, we make the teeth from a D3 to OM3. And now he's showing off his smile. Now he's keep topping up. His teeth is OM1 now, much whiter than OM3. He chop up every 6 months now. How about severe tetracycline stained teeth like this? This is a very nice story I'd like to share with you. Thomas, 39 years old, Caucasian. And one Friday he went to a party, and in a party he bumped into a dentist. And then, you know, we are dentists. We go to a party, anyone know that we are dentists, they will come around and ask for free advice, always. And Thomas, exactly the same. Went up and the dentist, really, he was a dentist, he's a dentist, and say, oh, I've just been to Harley Street that afternoon. And then I'm going to have my teeth veneered because I got these tetracycline stained teeth now. I can afford it. I just want to look good. And they even contour the teeth for me so that make a shape for me that was slightly small. And then I don't have a name of this dentist, but this dentist probably been to my course, my seminar. And he told Thomas that before you have the teeth grind down and veneered, he said you should go and see Dr. Wyman Chan. Maybe he have other options for you. So Tom called in Monday and make an appointment, and very curious, coming in and say, what can you do for me, Dr. Chan? Say, everybody say only veneers or crowns can improve the aesthetic of my teeth. I say that we have a third option. We can do non-invasive teeth whitening, but it would take a while. As a veneer crown, maybe 1 or 2 weeks, your teeth will go white, but need some grinding of the teeth, maybe a little bit invasive, could be minimal, could be more invasive, depending on whether it's veneers or crowns. So Thomas said, are you serious? You mean you can make my teeth look better without grinding them down? I said, yes, I could. So we started the treatment. I offer him a 12 weeks, a 3 months regime. So the teeth are pretty dark, C4, A4, C4, A4, you can see that. And baseline. And 9 weeks later, we got pretty good result. And then 12 weeks later, we got very good result. And say we could go on. And then I asked my colleague to file down the composite filling being put here, because otherwise it will affect my treatment. So, and then I asked Tom to go to find a dentist, and then just have the contouring done there, because that is maybe too thin, maybe it may break. So Tom is very happy. Okay, and not only I can make tetracycline teeth white. This is one of my students, Dr. Gao, in Beijing. He's done many cases. It's done dozens of cases now. This is one of his very first tetracycline cases I'll show you. Now his work is so much better. Just I'm so proud. I'm so proud of the students that I taught in China. And Miss Kong, 35 years old, prefer a non-invasive solution of a smile. So Dr. Gao, I actually guided him. I gave him a treatment plan. I gave him a 4-month treatment plan, but he did all this in three months. So I think that was really impressive. Another certified dentist, Dr. Ouyang, who's a PhD in an orthodontist, got a PhD, work in a private clinic, pretty smart dental in Beijing. And we were working together, and they do a lot of fixed braces. She does a lot of Invisalign, but her colleagues, two other orthodontists there, they do mainly fixed. And this is what they discover after they done the fixed braces. They found that the teeth demineralized. That's what they realized. They asked me, "Can we do anything about this?" I said, "Yes, I've been looking into this. I've been doing some work on this as well." I say, "Why don't you give it a go and see whether we can change the color and make it more even." The patient's just not happy about the unevenness. The teeth are nice and straight, but they are not sightly because of the white patches. Started when she was 19 years old, and then 2 years fixed braces. So she did just 10 days, just trace with the products, with the teeth whitening products. And when she showed it to me, I couldn't believe my eyes. I was shocked. So I mean, we can do things like this now. So the scope is enormous now, what we can do with hydrogen peroxide. So this is an amazing result. Only 10 days. Imagine if we do 2 weeks, 2 months, what the result can lead to. Okay, and many people say, how long can it last? It can last a long time. I think it lasts too long. For example, this case, we have 2010, before the canine, and then after we're done the treatment, it's gone to a B1, the canine, and the front teeth from A3, A2 gone to 1M1. And then the patient hasn't had anything done in 8.5 years and came back for review. And I was surprised and also quite pleased to see that it lasted quite long. I see the color obviously gone down slightly, but still A1, gone down B1, but 8.5 years is still so much whiter than what it was before. This is 8.5 years. Obviously, I have many 2 years result, 3 year result, but 8.5 years. This is the longest I have for a review. Nicola, born in 1990. She got a white patches there. A very interesting case. That's why I'm going to show you this. Can you see a tooth has so many different colors? I just want to look at what color that white patches is, and then it show me is OM3. So I know that I need to get a teeth to OM3 to make that white patches just disappear into the surrounding of OM3, just like magic. So the aim is to make the teeth to OM3, and that will disappear. Okay, so came to see me 2009 when she was 21, and then came back, nothing done before, came back for another treatment, another retreatment 5 years later. And you see that is not there yet because there's no OM3 yet. So you still can see the white patches there, or maybe the mineralization hasn't taken place. But then came back to see me 2019. She came back in 2016 as well. So you just come back every 2, 3, 5 years for retreatment. And that is nearly disappear. But I just saw her. I'm so pleased when she booked an appointment. I was stuck in China for 9 months. I came back. She wanted to see me. When she came in, I was so happy when I took the crystal eye. That's totally gone. I know that I've gone into OM3 now. It's gone. So beautiful. The white patch is not noticeable now. So imagine that you start with that, and 12 years later, your teeth is still so beautiful. They do last a long time, and they can last forever if you chop it up every year. So let's look at the scope and limitation of teeth whitening. Yes, we know that it cannot align teeth. So if the teeth are crowding, we cannot change that. Yes, we know that if the tooth shape is not ideal, we cannot change that either, but we can change the color. That we can do. We done a survey in 2010 because at that time an orthodontist worked with me, and I try to refer I try to upsell after their teeth whitening done. I ask them whether do you like to have if the teeth are not straight or crowded, whether they have orthodontic treatment done. This is try to refer to our orthodontists. I found that 82% of the patients are happy just with their teeth whitened, even though they are not straight. Not those really crooked teeth. I'm talking about like mild crowding. They really don't mind. But in my experience, when the teeth are nice and white like OM3, they look really nice, even though we have a little bit unevenness. It looks so natural, really natural. And I think that 82% is a big proportion of our population are happy just to have the teeth whitened and nothing else done. Obviously, I think it's a cost as well, because if you do orthodontic treatment, the teeth whitening, maybe between like 500 to 1,000 pounds. But talk about orthodontic treatment, here is about 6,000 pounds. It's a lot more. So I think probably it's a cost as well that put a lot of people off having to have the treatment done. And thank you. I started 10 minutes earlier, so I got plenty of time for questions. Thank you, Andrew. I'm ready to take questions.
Thank you, Dr. Chan. If there's any big questions, if anybody wants to pop it in the chat now for Dr. Chan while we've still got him.
Yeah, I think there's a lot of chat there. Let me have a look. Okay, let me see.
Anyone online want to ask Dr. Chan a question?
Okay, to say thank you so much, but no question. Okay.
Lots of compliments, obviously.
Okay, this is thank you for the great presentation. Did you use any additional material to mineralize the teeth? Very, very interesting question, because many of my students ask me that. The answer is no. But it's all in the products. It's all in the products. If you use good products, it's a science, and some products can it's not the product that that do the remineralization, because in the products there's no calcium, no phosphate, but you could have something. You've got something that will encourage the phosphate and the calcium and phosphate from our saliva to deposit it onto the teeth surfaces. That is the key. That's a secret, and that's a magic. Okay, this is a great question.
Thank you. Do we have any other questions for Dr. Chan?
Okay, if there's no question, I'd like Andrew and you. I'll pass it all back to you.
Thank you very much, Dr. Chan. We really appreciate your time today.
You're welcome. I'm looking forward to see you back in Birmingham soon when all this pandemic is over.
Yes, I hope so too. Just for the record, Dr. Chan also whitened my teeth, and I can vouch that the results were absolutely amazing.
I also teach at the College of Medicine and Dentistry, and that's why I teach MSc students. If you guys want to learn more about teeth whitening, please enroll. You're going to be an amazing teeth whitening the dentist, as well as an aesthetic, as well as a restorative dentist.
Thank you, Dr. Chan. That's great.
Okay, I say goodbye and thank you. And thank you for watching. So if you want to get hold of me, you can get through Andrew, and Andrew got all my contact details.
Thank you, Dr. Chan. That's great. Thank you for your time.
Oh, you're welcome.
Thank you. I'm just going to check if Dr. Ziad is available now, because we can just move on with the next lecture if he is. Just bear with me.
I am available. Hi, Andrew.
Fantastic. Thank you, Ziad. Nice to see your face, even though I only saw you yesterday in the College of Dentistry, so it's nice to see you again. I'll give you an introduction. So this is Professor Ziad Al-Ani, Dr. Al-Ani was awarded his MSc in prosthodontics from Manchester University in 1999. In 2004, he was awarded his doctorate from the same university. The title of his thesis was Studies in Temporomandibular Disorders and Occlusion. He was appointed by Manchester University as a clinical teacher in restorative dentistry in 2004, as well as a research coordinator for the TMD clinic, and is recently a senior lecturer at Glasgow Dental Hospital and School. In 2006, he obtained MFDS from the Royal College of Surgeons in Edinburgh. In recognition of his teaching activities, he was awarded the status of Fellow of Higher Education Academy in 2010. Dr. Al-Ani was one of the 2 finalists in the Teacher of the Year 2006, as awarded by the Dental Defence Union. The award recognised excellence in dental education. He was again a nominee for the 2007 and 2008 Dentist Teacher of the Year Award by the Dental Defence Union after nominations made by undergraduate students at Manchester Dental School. He has published numerous articles on occlusion and TMD in peer-reviewed scientific papers, and he is the author of the book Temporomandibular Disorders, a Problem-Based Approach, and the book Practical Procedures in Dental Occlusion. Today's lecture is on occlusal considerations in anterior restorations. Thank you, Professor Ziad.
Thank you very much, Andrew, and thanks for inviting me to speak at this meeting. I'm well known by my interactive lectures, actually, and I want always the audience to be engaged in the lecture, and I have reasons for that. I'll show that in a minute. Can I ask all the participants if you please can go on this website, polf.com/Ziad-745. I want you to vote for a couple of questions or maybe more, just to as an icebreaking first. And the other thing is some of the seeking opinions about what you're doing at the moment in practice. So please go everybody to this and using your smartphone, polf.com/745, and you should see the following one. You should see something like this one, okay? Right, and just put your actual name, please. Don't put any funny names because I might expose the names. Trust me, I'm joking. This is anonymous. All right, so please just put your actual name in case of if you want you to see your scores or a proof of your attendance as well, that would be good. So we can actually prove that you attended the lectures for your CPD or other things. So I just want to make sure that everybody went to this polf.com/Ziad-745 and you already registered your name to be able to vote in this lecture. Okay.
Just to help everyone, I've just popped it into the chat as well so they can copy and paste it. All right.
Thank you very much, Andrew. That's really useful. Thank you. Okay, so yes, copy and paste if you want in your browser. Just put it in normal browser. You should see this. I just had some screenshots of what you may see in your smartphone. Okay. Right, so let's start. Oh, well, already people started. I want you, first of all, just to put a vote here in which category best describes you here. So some people start already voting. Well done. Okay, getting more. Yeah, I can see more GDPs, general dental practitioners, one specialist. Very good. Okay. Yeah, people are just voting as they register now. I know that's really good. So the system works very well. And I'll show you the reason why I like actually to use this in a lecture like occlusion. Occlusion is a dry topic. People find it sometimes hard to understand or hard to listen to sometimes. It's really, really good to make it interactive. So people are voting already, so that's fine. I know the link is here, guys, still here, and it is in the chat box, posted kindly by Andrew. Okay, I can see a few people voting. So most of them, the GDPs and 2 specialists are getting more voting now. So let's move on. And this is the reason for why I like my Zoom lectures to be interactive, because traditional lectures on Zoom, not terribly impressive anymore. I don't want anybody like this or nodding off in my lecture. So that's the reason for making it interactive. I believe in this. Tell me I forget, show me I remember, involve me I understand. And I like to put the chocolate on the top of the broccoli to make it delicious and to benefit from what's been underneath here. So putting some spices, some flavors on the top of the occlusion topic will make it easy to digest. So we know occlusion, the word occlusion is, by the way, the easiest definition in dentistry, if you want, and it's the most difficult to understand, and everybody believes in that. But because our lecture is about, you know, aesthetics, I tried actually to get some tips related to occlusion in anterior teeth, because when we say occlusion, people always think about the bite, about posterior teeth, but how about the anterior teeth? So look at that. The best restorative and periodontal care will fail with a bad occlusion. And if you don't get into, if you do get into trouble, and understanding the occlusion will generally get you out of it. If you don't understand the occlusion, you won't find an answer for some of the clinical problems. You don't have predictable results in terms of restorative dentistry. So again, don't overlook this very crucial part of examination, which is examining the occlusion. And the occlusion can be a soul-destroying experience. And I know many of my colleagues who had years in practice, they had, or they met patients who actually fed up with, you know, patching up their restorations and keep fracturing again. But the question should be asked here, is the problem in the materials, in the dental materials here, or is something else? There's something else, could be the occlusion as one important factor of causing this catastrophic fail. And you have to remember that occlusion is more than adjusting high occlusal contacts, is more than detecting it with the articulating paper and adjusting it. This is not occlusion. So we need to now think beyond this. We need to go now the extra mile of examining the occlusion to know what could be the factors of causing this fail. So let me put this like a slide in front of you on the screen. And, you know, I just want you to think about what could be the cause of this drifting of upper incisors of this patient, chipped and worn anterior teeth of the other patient, repeated fracturing of class 4 incisor restorations, composite restorations, for example, like previous veneers keep breaking and chipping off. All of this related to, again, anterior teeth and anterior restorations. What could be the reason? When, let's vote for that. When occlusal trauma is not evident. I put that because I know that people, you can type in now, guys. I know that some people will say now occlusal trauma. I'm sure that will happen. So occlusal trauma, this is a wide term, but what we mean by occlusal trauma? Is it a high restoration? Is a high, like a restoration not done in a proper occlusion because it's actually raising the bite, or what is the main reason? So let's see what the participants think about that. So just put a couple of words here. What could be the reason for these clinical problems? Let's see if there is any answers. Okay. No responses yet. So people are shy to vote. Just write anything you think is the reason for failure of this. Don't worry, I'm not going to show names, guys. Names not going to be shown here. It's anonymous, I promise. Okay, so no voting yet. Come on, guys, any votes here? Bruxism. Ah, well done. The first vote here, first brave one. Parafunction, you mean here. Okay. Erosion. Okay, that could be the reason from palatal erosion here, but you can see fracture of the restorations, chipping of like a veneer. Okay, don't think erosion is the reason here. Parafunction and bruxism, yes, that could be the reason for that. Yeah. Other than that, if say that the patient, we examine the patient is not aware of bruxism, but you know that only 20% of patients, they can tell that they clench and grind their teeth. And we usually know by the partner who couldn't sleep because of the noise of clenching and grinding. But again, we have other methods of detecting the signs of active bruxism in soft tissues. But say that we couldn't find any evidence of parafunction or bruxism. What could be other reasons? But this is very, very sensible answer. Okay, let's see. Guys, there is something called the envelope of movement. So the jaw has some sort of different points between centric relation, which is the jaw relationship, the centric occlusion or ICP, intercuspal position, which is this is the teeth relationship, and we can push the jaw forward, we can open maximally. So the jaw has some shape of an envelope, we call it Posselt envelope, and everybody knows about that. And we have here two areas, which is centric occlusion and centric relation. And look at this study by Pamiger, which shows out of 686 contacts, 588 were in centric occlusion and 15 in centric relation. And the other study showed that of 180 swallows, we have 162 tooth contact in centric occlusion and 5 in centric relation. That means this position shouldn't be neglected, the centric relation. So it is jaw relationship. It might not be within the function, the normal function, but that could be utilized by some patients, as this studies showed. And this studies actually is telemetric registration. So it shows there is an evidence that the use of this jaw relationship. So some people might be actually having some function between centric relation and centric occlusion. So there are some movements, for example. And when you do your occlusal examination, one of the important things which shouldn't be overlooked when you examine the occlusion is to examine the centric occlusion, which is the bite, the habitual bite, the maximum intercuspation, okay, and the centric relation. So you should be able to develop the skill to examine this in order to see the direction of the slide. The reason for that, because if your restorations will change this direction of the slide from centric relation to centric occlusion, or will interfere with this envelope, which I showed you here, okay, this might actually cause some bad effects on the restorations or on the masticatory system itself. So centric relation is a concept, of course, I can't cover it in this lecture, but you need to learn this skill. And we use it in restorative dentistry in different aspects. So let me give you some examples. First of all, in order to adopt the conformative approach, which I mentioned already, that we don't actually want to change this relationship between centric relation and centric occlusion. We don't want to change the slide, for example, okay, in order not that to affect the masticatory system. So we need to keep the envelope of movement as it is for patients when we do simple restorative dentistry. In order to do that, you need to be able to examine the centric relation, examine the slide between the centric relation and intercuspal position before you start your restorative work, and recording it and making sure after you providing your restorations that this wasn't changed. This is the important part in simple restorative dentistry, which we call it conformative approach. Now, when you plan to reorganize the occlusion, when you want to change the OVD, for example, we want to manage a case of tooth surface loss. We don't have now anymore a reproducible position in ICP, in intercuspal position. We don't have a reproducible bite. So we need another reference point, another reproducible, repeatable, reliable 3 Rs position, which is the centric relation, because centric relation is still there, because it is jaw relationship. It's not teeth relationship. Teeth are worn down, teeth are gone. I still have another position which I can build up my restorations on, which is called centric relation, and it is reproducible and it is original. I mean, in the patient's envelope, I didn't create any new position. And this is the same position we use when we do complete dentures, of course. when we try to make a stabilization splint to manage a patient with myofascial pain or a patient with a paroxysm, or we want to reuse a splint to test the increase of OVD in advanced restorative dentistry when we manage tooth surface loss, for example, I need again to make this splint in centric relation. So I need to learn how to get and register centric relation. And I highlighted the last one, which is the slide between RCP and ICP could be associated with some occlusive problems in some patients. So these occlusive problems I showed you, I'll come back to it. These occlusive problems shown in this slide actually could be a result of a deflective contact between RCP and ICP. You won't imagine that a problem at the back teeth, for example, causing a problem in anterior teeth, you know, and I'll show you how in the next slides. And this concept of centric relation, by the way, of course, is well known in the field of occlusion. And Peter Dawson, who's one of the pioneers in occlusion around the world, he said this, which I quoted: out of the factors of occlusion, centric relation is the single most important that must be understood by every dentist who works on teeth. And this guy spent his entire life career in occlusion, and he's the founder of Dawson's Academy, of course, in the United States, a well-known academy. And he published this book, which again talks in details about centric relation and the importance of knowing that and the importance of developing the technique of knowing them. So coming back to our main point, the slide between RCP, which is the retruded contact position in centric relation, and between the ICP could be deflective. That means it actually causes an extensive movement of the jaw. And that might be the cause for wear, drifting, mobility, and atypical loss of bone support in the anterior teeth. For example, if you have a patient, when you probe it with the perio probe, you find no perio evident in the other teeth, but there is a big bony pocket around one anterior tooth. You might say this is occlusal trauma, but this is a general term. If we want to know what type of occlusal trauma, of course, we need actually to check that, and checking the contact between RCP and ICP is one of the examinations should be done here. And correcting it, it actually, most of the cases will reduce the trauma on the anterior tooth. So again, a problem in deflective contact from RCP to ICP causing a problem in the anterior teeth. So we need to check this slide. So we need to learn this technique, how to find, the centric relation, and check this slide, which could be the cause of some anterior teeth tooth surface loss here, and see the slide between RCP and ICP. And assessing the occlusion, of course, it's a full package, guys. It's not only putting the patient, checking the ICP and RCP. You need to get the models articulated in semi-adjustable articulators using a face bow, of course, and we can actually demonstrate all of these movements on the articulator itself. And learning this skill, this is acquired skill, improves with practice. You need to practice that in order to master this centric relation. Okay. So the way of the operators, how the operator is sitting in the chair, the level of for example, the elbows and the patient's supine position, and how the patient's neck extended slightly, chin pointed upwards. All of these factors are important to get the centric relation found and registered correctly. And even the ways of putting the thumbs and the fingers, we try to manipulate the jaw here. It's called bimanual manipulation. We don't push the jaw, of course. It's like a big topic, the centric relation, as I said. And I mean, there's not a scope of this lecture, but one of the elements you need to master if you want to really to control the occlusion and know the reasons for some failed restorations which are related to occlusion, you need to master the technique of finding centric relation and watching the slide from RCP to ICP, of course. Okay, I want you now, this is, so the first take-home message to learn that you need to examine the occlusion, you need to examine the articulatory system, of course, in general, examining the TMJs, the muscles of mastications and the occlusion, and within the occlusal examination, you need to be really competent at finding centric relation and recording it. Now, I I want to touch on other factors which might cause problems of the anterior teeth. I want you using your fingertips. Yeah, I've got some now locations here. Just click on the photo, which you think it's like the correct shape of a crown in terms of morphology. So I have participants clicked on this shape. I have now participants clicking on this one here. Okay, let's see who's the winner for this one. Okay, so more clicks on the one on the left-hand side. Okay, few on the right-hand side only. Let's see. Keep on clicking, guys. Okay, more to the left-hand side. Yes, I think, yeah, this makes sense. Look at the palatal aspect of the anterior crown here as opposed to the one here. So we need to consider the palatal aspect carefully when we prepare the crowns, guys, for anterior restorations, because we need to consider the movement of the mandible on this like palatal aspects in protrusion. And this shouldn't be like a slope or thick one, thick palatal surface or cingulum, because that will obstruct the protrusive movement, as you can see here. So the protrusive movement needs to be done smoothly in the correct shape of the like palatal aspect of the anterior tooth. This actually leads us to a concept called the freedom-centric, which is freedom-centric. It means that the teeth, when they occlude posteriorly, they should allow slight movement of the cusp tip inside the fossa rather than to be a wedge. So the posterior teeth, when they occlude, the cusp needs to have some room for it to move slightly forward. If you have the tip here, the fossa is pointed, and you have the palatal aspect is thick, this actually will allow no freedom-centric. And that means we have excessive forces applied on the anterior teeth. So two things you have to remember here. Anterior teeth shouldn't be a thick slope here, should be the correct morphology on the palatal aspect when you restore that, and posterior teeth, which are related to anterior teeth as well, should have a room in the fossa for the freedom-centric. So freedom-centric is related to both the posterior and the anterior in order to achieve it, okay? Which is called long-centric sometimes in other books. So again, this will not allow freedom-centric here, but this one will allow it. So you might do actually some anterior restorations, which they look marvelous. They look absolutely great in terms of the aesthetic, but the patient feels them locked. Locked means they can't have any room of movement there. And with time, you can tell the consequences of that. So again, because of neglecting the palatal aspects of the anterior teeth to be reproduced in the correct morphology, or a problem in restoring posterior teeth when you make the fossa like point fossa. So again, it's not enough only to give some room here. You need to give the correct morphology. The technician can do any crown for you here with a thin layer of porcelain of PFM, but with a wrong morphology. So something like, okay, you look after the labial aspects of the teeth, but how about the palatal aspects of the teeth? So if you don't get the correct forward movement, the correct occlusion here, you will end up with the failed anterior restorations because of the poor morphology of the anterior palatal aspects. Okay, so, and this is quite common. That could be related to lack of ferrule effect, of course, here. But again, ferrule effect, the results of the lack of ferrule effect is more of longitudinal fracture of the root rather than, you know, de-cementing of the post-crown here. So remember, if you go back to our undergraduate knowledge about the preparation of the anterior teeth, you need it to be in two planes here, of course. And guess what? Don't be shy of, or you feel that you're above it, that you use the silicone index. Even with an expert, there is no harm with using this one, which will make a big difference on knowing, you know, that you've got enough preparation and the exact shape with the cingulum and the palatal aspect of the teeth, especially in important teeth like canines. We'll talk about canines as well. why it's very important to reproduce the palatal aspect correctly. So using the correct bare while preparation, using silicone index will help a lot in getting this sorted. Okay, so if you want to get a good function, you need to get a good morphology in your preparation. And if you want to your technician to provide you with the good restoration with the excellent morphology, you need your preparation to be spot on in first place. So always measure the thickness of the temporary. The thickness of the temporary will give you an idea about your preparation and about, that you have enough room and the shape of it as well. Okay, so that's a good opportunity not to be missed here. Freedom and centric, how would you know that if you have a freedom and centric or not? If you have your fingers are cleaned now while you're listening to my lecture, okay, guys, or sanitized, okay, you make sure that your hands are clean. You can put your finger on the labial aspect of the anterior, upper anterior, or upper incisors, and just tap on your back teeth, okay? If you feel any sort of tremor, a jerking movement there and the anterior teeth, that means you don't have a freedom and centric. This is a simple one to test. This is like a not very objective, of course, this is subjective assessment for that, but gives you an idea whether you have freedom and centric or not. Okay, I'm sure now people are testing their teeth and you can tell. Again, this is an example of how to create a freedom and centric by, or helping creating freedom and centric by increasing the width of the fossa. This fossa will allow freedom and centric occlusion, but this one, the pointed one, will not allow it. In terms of implants, for example, this is very important, whether it are anterior implants or posterior implants, you need to reduce the load on them. And, it's always advisable when you have implants supported crown to have a big fossa here to allow some freedom and centric wider than usual, okay? So about 2 to 3 millimeters platform, with the opposing teeth. So no freedom and centric is described actually as what we call it constricted chewing pattern, or CCP. This restricted envelope of function, it might actually cause some problems or, chipping of the anterior porcelain or, crowns. Which is, again, something that needs to be always in mind. So patient with the CCP might present with chipped, worn anterior teeth and sometimes TMJ symptoms. You have to be careful about the relationship between like the TMJ or TMD and occlusion. I wrote a review article about that published last year in Journal of Primary Dental Care about this, and this is still not supported by evidence, that any occlusive problems might cause a TMD. So I have to be careful about that. But here we're talking about the restorations. So something like that, these meant to be palatal aspects of the teeth. Of course, they should look like a labial aspects of the teeth. You can actually warn them two faces there. So again, especially in patients class 2, DEF2, the skeletal pattern is important as well here. Bulky cingulums, all of these will cause this constricted chewing pattern. How would you examine it more precisely than tapping on your back teeth and putting the finger on the labial aspects I just showed you? You can use what we call the secret of success in occlusion, which is shim stock foil. Okay, shim stock foil. I'm going to talk about it in a minute in a little bit of details and how or the advantages of using it. So what we do, we can ask the patient to sit upright here and close the teeth together, putting the shim stock foil held by Miller's forceps here, as you can see. And then the patient can actually, catch the shim stock between the teeth there, so we can't pull it through. And then we change the patient's head position, so tilt it backwards. And we'll see if the shim stock is still held between the teeth, this patient has this constructed chewing pattern, or the no freedom and centric, because even changing the position of the condyles didn't change the contact point here. So the patient have a very close contact between the anterior teeth in other terms. So shim stock foil, you can, I'm sure many of my colleagues, they know it. It's 8 microns foil. It has many advantages. So let me see how many of you using shim stock foil, guys. If you can vote for that, do you use shim stock foil? Yes or no? Okay, so getting some votes here. Almost 50-50. Okay, so people who are voting here, we have the vast majority not using this shim stock foil. This is one of the take-home messages, guys, from my brief lecture today, is to get that in your drawer for occlusal examination. It is very useful. Foil it's versatile, has multiple use in dental practice. Let me show you some of the use of that. It is actually a feeler gauge. This is the definition of the shim stock. So usually we use it in practice to check whether these restorations, they have occlusion or they are infra-occluded. You see what I mean? Because 8 microns thickness there. It doesn't have ink, of course. It doesn't mark the teeth. So the importance of that, you can actually check whether the articulation of models are correct or not. Because when you take impressions for study models and you pour them with the stone and cast, and you put them in articulator and you put the bite registration material, sometimes there are potential errors there in the articulation. So you have an 8 microns gauge. So if you put this 8 microns between the patient's teeth, all right, and then record that, for example, the upper 6 with the lower 6, they hold the shim stock. The upper 4, it doesn't hold the shim stock because there's a little bit of gap. This is the patient's occlusion. And you can ask the technician or yourself, if you have your articulated models in the articulator, to check by putting the shim stock between the stone, between the study models, okay? And then check whether it's the same clinically. That means your articulation is spot on. Okay, and vice versa. So if, for example, your clinical record showing that upper 6 with the lower 6, they are catching the shim stock here, but on the lab, it's pulled through, that means there is a problem in the articulation. As simple as that. Okay, so you have an accuracy down to 8 microns with that. The other advantage of using it, this is something, you know, in field of occlusion, guys, most of it, it's not evidence-based. Let's talk about the facts there. There are some suggestions from experience, okay, but we don't have like evidence-based studies to show it is a must to use this protocol, for example, or not, in most of the aspects of occlusion. But one of the things which is advisable, let's say, rather than a protocol, is to, when you do implants dentistry, you should have some sort of clearance. It was about 30 microns between the implant-supported prosthesis or crown and, again, the opposing teeth. In order to do that, how would you gauge these 30 microns? We have 8 microns thickness of the shim stock. So if we fold it to 4 layers there, 4 layers should be grip between the teeth there, but 3 layers should be pulled through. You see what I mean? That means there is a clearance by 30 microns. It doesn't need, you know, extensive math skills to figure this out. So again, yes, we can use it to estimate how much clearance we want. One of the things introduced by this company, you know, which will be very helpful, because somebody might ask, how would I compare the clinical findings of shim stock hold with the lab? You can get this sheet. I'm happy to post it for you. It's available on the web, I'm sure. And it's called shim stock hold. It's very simple sheet, can be used easily. So you can actually put marks, for example, between 1-1 and 4-1. Is the shim stock held between these teeth? Put yes or no. Again, between 1-6 and 4-6, we found it held, put yes. And then send this to the, over to the technician. The technician will compare it with the cast and will make sure that the articulation was absolutely spot on, correct. Okay, so again, a sheet like this one, simple one, can facilitate the communication between you and the technician regarding the accuracy of articulation. So coming back to the management of the constricted chewing pattern audio I showed you, we said that, okay, the patient doesn't have freedom in centric, and you provide the patient with some composite restorations, for example, anterior teeth. So if the patient has this strong bite anteriorly, so there is no freedom in centric, let's say, you need to do something about giving some sort of easing of this area. If we use thin articulating paper, you might actually remove some of the occlusal contacts and create a gap between the teeth. We don't want infra-occluded restorations, guys. This will cause over eruption and will cause disturbance of the occlusion of the patient. Unless we do something like DAL concept, which is completely different there, you know, when you leave some gaps in posterior teeth, this is monitored, okay? But again, coming back to this one, so use 200 microns articulating papers and ask the patient to chew on that and get some marks there. These are marked by 200 microns. Easing this one until you don't have marks, and use the thin articulated paper, which is 40, you should have some marks there. So this will create some room in anterior teeth and reduce the load on them in case of the CCP, as we said, okay? So this is something to avoid as a preventive measure, to avoid problems in your anterior restorations in a patient with a CCP or lack of freedom in centric. Remember, guys, other things which is very important, when we talk about anterior teeth, we have canines as well. When you involve your canines in restorations, you have to be extremely careful about not disturbing the pre-existing occlusal scheme. If the patient has canine guidance, for example, I don't want to create an interference. I need to keep this guidance, okay? If the patient has group function, I need to keep this group function. I'm talking about simple restorative dentistry to conformative approach. So that's why, like, and you know, extensive care should be put there to reproduce the palatal aspects of the canines. You remember palatal aspects of the canines, they're not bulky, they're not like a slope. That we have a ridge, we have two fossa or slopes there. So this is actually there for a purpose, because the canine guidance could be on expense of one of these slopes. If you make it bulky, if you make it like a belly shape there, that will obstruct the movement of the jaw and will actually lock the teeth in the lateral extensions. And we see a lot of problems with, unfortunately, full mouth, porcelain, full mouth rehabilitation with porcelain crowns or veneers, whatever, and the patient, okay, was over the moon after receiving this because it's marvelous aesthetics, but as simple as that, they can't move the jaw, it's locked. Those patients who have remunitory chewing pattern, they will not be able to do that. They're not be able to actually slide the jaw right or left because you actually obstructed it with the poor morphology of the canine, something like that, bulky palatal surface. Okay, so again, this won't help. This is not the palatal aspect of the canine, something like that reasonably, okay? So look after that. The poor morphology will end up with poor guidance. So the patient will not be able to make lateral extensions with the good guidance. So most of these restorations will be replaced not only for the aesthetic reason because they're not good, but sometimes they're aesthetically acceptable, as I said, but functionally they're not. So you have to look after this area when you do the palatal preparation of the canine, of course. So good prep, good morphology of restoration, better knowledge of tooth morphology can help to optimize that. So that case actually needed to be redone with new wax up. Wax up using semi-adjustable articulator should, of course, achieve this lateral movement with the canine guidance or groove function, and by looking after the shapes of the upper and lower canines, either palatal aspects or the labial aspects of the lower canines here, to achieve this disclusion in the lateral exertions. Whether you use a digital system or using traditional way is the same thing. The same principles have to be applied in looking after the morphology of the anterior teeth and especially the canines. This is a case published in BDJ a long time ago, which showed the patient couldn't tolerate this bridge, and the problem was the bulky palatal surface of the canine. The first thing you do here, guys, before replacing the existing bridge with a brand new one, get the temporary. And on the temporary, try to achieve some guidance here on the teeth. Once the patient is happy with that, and most of the cases, patient will be absolutely satisfied by having a guidance there, you can actually copy that in your final restorations. Okay. The other thing is to consider the protrusive movements as well. The protrusive movements, when you have like a class 4 restoration or you have a veneer, make sure if you have guidance on adjacent teeth, on a sound tooth in protrusive movement, you don't need contact and protrusive movement of the restoration, as long as there is a sound tooth which can actually ensure the guidance there. So if this tooth can ensure a protrusive guidance, you don't need a contact on your restoration. So that will save you troubles, possible troubles of that. Especially if you have thin veneers, you need to avoid the guidance on them. And when you have veneers like that, try to get the occlusal contacts mainly, not on interface, of course, between the restoration and the tooth. Try to get the occlusal contact in the sound tooth, and the guidance, if you can avoid it, if there is like adjacent tooth, which is natural, make it on expense of that tooth. The last point I want to mention here, guys, about, we're talking about the importance of the palatal aspects of the anterior teeth, okay, in terms of the guidance, the protrusive movements. So when you prepare the teeth, if you prepare multiple anterior teeth, eventually you're gonna end up with losing the shape or the morphology of the palatal aspects because you prepare them. So you send the technician the impression, and they've got the cast and everything, and try to wax up these restorations. So they wax them up, okay, could be like a nice wax up in the palatal aspects, but it is not the same morphology exactly like the one before preparation. I think you got the point, okay? So we're losing here a guide. So if you prepare the teeth, I don't have an adjacent tooth which shows me the shape of the palatal teeth for this specific patient. That might differ between patients. So what would you do? It's advisable in these cases is what you do is the technique one is to do what you call the crown about method. This is a modified photo just to explain what I want to say. It's crown about method that you do every other tooth. So prepare one tooth, leave one. Don't do them at one go. Okay, this will cost you and the patient an extra visit, but that will help the technician in waxing up the palatal aspect of this tooth by looking at the adjacent tooth still there. You see what I mean? And then when you fit the crown here, you can get, the technician can get the morphology from the crown, which is already in place. Somebody might say, oh, how about the shade? Shade, of course, you're selecting the shade carefully, and the technicians using the same system. There is no here any sort of concerns about making another visit and copying the same shade. That's not a problem at all. But you need here 2 impressions, of course, and you need more than 1 visit. But that will ensure the palatal aspects is being reproduced exactly like the teeth before preparation. So we can actually, as I said, sorry, just move this one. Okay, okay. Let me just move this one, sorry. Yes, so now the other technique, so that one, when you have teeth, you need to prepare. The other technique, when you have tooth surface loss like this one, so you don't have originally any sort of morphology of the teeth, and you need to crown these teeth of the posterior, for example, the definitive, including the posterior teeth, the definitive treatment is like crowns on the anterior teeth. Get the temporary right. So once you get the temporary right, what you do, make sure that the patient, of course, using the accurate impressions, the face bow, and you articulated them, and the semi-adjustable articulator has done the wax up, and you fabricated the temporary. So these are the stages. Make sure when you do the temporary, okay, that you get the occlusion in static and dynamic occlusion right in terms of the guidance. So we'll spend some time, adjusting the palatal aspects of the temporary until you get the guidance, of course, between posterior and anterior teeth. And then you now satisfied, of course, I just mentioned that the temporary restorations here, although we tell them temporary, call them temporary, it's more than temporary, they are provisional. The reason for that, because it's not only a cap to, cover the tooth, it's actually testing the tolerance of these restorations and the OVD and the occlusal scheme which we produce. So it's more than a temporary. I like this article by Professor Trevor Burke, long time ago, it's 2005, which is saying that the provision is not just a temporary. talking about the provisional crowns. So get yourself a good material of the provisional crowns in order to test the occlusal scheme as well. So once you get that, now the temporary is ready, and it's actually done according to a good occlusion, because you spend time testing the static occlusion, the lateral exertions, you adjusted them until you got the canine guidance or group functions sorted. Now I'm going to do the definitive restoration. So how would I copy the palatal aspects of the temporary, which is already in good occlusion, in my definitive restorations? Okay, so first of all, we need to check that there's no fracture, everything. If there is any fracture or mobility or sensitivity or cement failure or discomfort or drifting, that means the patient is not tolerating, of course, the occlusal scheme or the increase of OVD, if there is increase of OVD. So that's, of course, it is, sorted already. Now I want to copy the palatal aspects of that, which are in a good occlusion. In restorative dentistry, there is, after, for example, you've got the occlusion right here, you've got canine guidance, there is no canine here, so the medial aspect of the premolar took the guidance, so it's a perfect palatal aspect. I want to copy it in my definitive restorations. So we take the impressions, we take a face pull, of course, and we request what it's, let me show you that, or what's called copying anterior guidance. Copying the anterior guidance is a well-known procedure in restorative dentistry to actually copy the shape of the palatal aspects of the, especially of the temporaries in the lab. So how would you do that? You get a little bit of a duralay, the duralay, if everybody knows the duralay, which is self-cured acrylic material basically. And it's the advantage of using it gives you good working time. You get it like a dough, right? So on the semi-adjustable articulator, that's in the lab. So you have here, pay attention to this, guys. This is an impression, and this a cast of the temporaries, of the provisionals. So we took an impression of the temporaries or the provisionals, and we have a cast here. We articulated them. The dough here is soft. So what we do in articulator, we try to move the articulator forward. We move it to the lateral side, right-hand side, left-hand side, lateral exertions. We do all the dynamic movements. The incisal pin here and the articulator now is going to create a shape inside the dough itself, inside the duralay. And this shape is based on how the lower moving on the upper is the opposite in the articulator, of course, based on the shape of the temporary from inside, because this will create a shape which looks like the palatal aspects of the temporary, because the movement is done by the temporaries here. So have something like that on the table itself. So what we do now, look at that. This is the, again, a close up. This is the temporary, okay? This is the provisionals, and moving now them on the articulator, we created a shape here. So let's show that in this illustration. So these are the temporaries moving. Look at that. The shape created here looks like the shape of the palatal aspects here, because that's exactly how the jaw is moving on this particular patient. Now we have we remove the temporaries from the articulator. We get the prepared teeth, and the prepared teeth now is gonna be waxed up. The wax should actually make the same movement here, and the guide for us is this template here. So say, for example, we wax it up this way, right? And we try to move, the jaw is not moving. We carve it, remove it from it until this movement happening here. So this shape here of the template will guide us to the shape of the palatal aspect. So by doing that, we copied the palatal aspects of the temporaries, which were done in a patient's mouth with a good occlusion. Maybe it's difficult to explain it sometimes, in slides. When I show you a video, we can do that in our teaching in the college. We show videos and we demonstrate that in the lab as well. But let me show you that, that the pin can move from this side to the side. This actually was soft, so created a shape here. The same one we use it when we create the final restoration. So you can see here, after waxing up, you can see that the shape is created here, and there is a smooth movement inside it. That means the palatal aspects of the anterior teeth is the same like the provisionals. I think we can stop here, but before that, most of the procedures, we put them together in a book, which is published already now. The hard copy is going to be on shelves in November. You can actually order the pre-order already now of a book called Practical Procedures in Dental Occlusion. Where my good friend Riyaz Yar, myself, in the quarantine, actually, we had a good chance to do some Zoom meetings actually to finalize this book, which is a book targeting general dental practitioners for in the subject of occlusion, and it's mainly practical procedures. So we try not to touch in details in the theory, but to make it like practical. And there is like a link for videos in a website. When you purchase the book, you can access to see all the practical procedures in the videos. So thank you very much for your listening, and I am happy to answer any questions if you have.
Thank you, Ziad. If anybody has any questions, can they pop it in the chat window, and then Ziad can have a read and answer them for you.
Okay. Okay, so thank you. I can't see any questions. Okay. So far, there is no questions. Okay.
Okay, I think got some thank yous coming in. So thank you very much, Professor Ziad. I don't think we've got any questions from you. But if anybody doesn't have any questions, they can contact the Knightsbridge Dental Care and send it to the email address info@kbac.uk. So Knightsbridge Academy.
Yes, I'm happy to see that, you know, the reason for silence is a clear presentation. It's not the opposite.
Absolutely. Everybody obviously understood everything, and you've, thank you very much. So thank you, Ziad. You can sign off now. Just want to check if Raj, are you with us and are you ready? If you're
I hope
able.
so. I hope you can see me as well.
I can see you and hear you clearly. So
excellent.
It's my pleasure to introduce Professor Raj Rajarayan, OBE. Raj Rajarayan is Professor and Head of Restorative Dentistry at the College of Medicine and Dentistry. He was past Dean at the Royal College of Surgeons in England and responsible for postgraduate dentistry for London as Associate Dean at the London Medical and Dental Deanery. He has delivered over 1,000 international lectures and has helped change continuing professional development in the UK. He was an advisor to the Secretary of State for Health, one of the three wise men to the Lord Chancellor on appointments of magistrates and judges, and a member of the General Dental Council. He was made an Officer of the Order of the British Empire by Her Majesty the Queen for his services to dentistry. I'm pleased to announce he's presenting on aesthetics and ethics. Is it a paradigm shift? Thank you, Raj.
Thank you very much, Andrew. Looks like I've got a lot more time to spend with you, if you so wish to have that time spent with me.
By all means, Raj.
Thank you. As head of restorative dentistry, I can't tell you how delighted I am to have Professor Shamir Mehta, Professor Ziad Al-Ani, and Professor Wyman Chan in my department. They are a great strength to our College of Medicine and Dentistry. And from the lectures that you have heard from them, you can see that there is a steep learning curve you can meet if you have your minds open. My lecture, because I'm head of department, can be more challenging, and therefore they gave me this topic, aesthetics and ethics. Is there a paradigm shift effectively? And I thought I'd share with you what is happening in the Western world and how it might affect you as well, because all lands come to the same pathway sooner or later. Of course, these are some advertisements from dental practices, and I envy them because I was in Harley Street in a referral-only practice, and I did not even have a business card. All my patients came in purely because my colleagues referred them, not because patients referred them, because colleagues referred them. And the one advantage of having a practice, which is a tertiary care practice, doing full mouth reconstructions and colleagues referring patients to you, is they don't usually complain about your bill. So anyway, other practices are not quite so fortunate, and they do have to advertise. And here's a very nice advertisement I have seen. And there's another one, even nicer, dedicated to creating beautiful smiles. And then, of course, your smile is our vision. But the question I need to ask is, yes, who is it? Who is it that does not do good teeth? Which practice does ugly teeth? Why is all this marketing so important, especially when you have so many other colleagues doing exactly the same thing you are? Or are they, is the question one needs to ask. So this is about practices, which are marketing. The next question I need to ask also is the dentists themselves. In the UK, we are very strictly regulated, less strictly now than we used to be regulated. So in those days, we could never advertise. Now we can advertise, but it is unusual, probably unexpected, for a dentist in the UK to call themselves the best cosmetic dentist. Even more unusual to be able to advertise as the best cosmetic dentist in a certain town. I mean, looking at this, I'm sure she probably is the best cosmetic dentist in Houston. But when you look at the qualifications, it's about the basic dental qualification anybody could ever have to do dentistry in any country. So with a box standard qualification, to call yourself a best cosmetic dentist, well, it takes a lot of courage. And I admire the courage of some people. And I wish I could be as courageous as some of the people who market. So I actually looked at more American websites. Yes, because I wanted to answer the question, what makes you the best? Whereas some people did not have any credentialing as to what makes them the best. Some people do. So for example, there's a Lux list of modern luxury. The winner here was a chap called Peter Boulden, and that means somebody else has credentialed him. But of course, what does a Lux list mean? Lux list has the best sommelier, that's wine people, the best chef, the best haute couture maker, the best dressmaker, all that kind of stuff. So, and the credentialing of this gentleman is that he's the distinction of being a fellow of the Academy of Comprehensive Aesthetics, now part of the Smile Source Network. And I thought, what on earth is that? In any case, I looked into this person because it was very admirable. I mean, I was envious of the position that this person had. And I found he also did a course on bulletproof mentality. What is a bulletproof mentality? Usually you have a bulletproof car when somebody's trying to shoot you. So why do you need a bulletproof mentality? And looking even further, I found another course, which was dealing with upset patients. Oops. Then when I looked at the credentials, I saw there was more than just the basic dental qualifications. There was a fellow of something, fellow of another thing, fellow of other things, and fellow of more things. And then I went in and looked to see what these fellowships were. And these fellowships are really based on a lot of societies where people get together and create a club and give each other fellowships. One or two of them actually, you have to answer a question paper and pass. But by and large, most of them are credentialed by being a thoroughly good person or knowing someone who has a good contact. Nevertheless, aesthetic dentistry is very important. Where would Tom Cruise be without getting his teeth fixed? I mean, so many actors, so many personalities, so many politicians, so many royalty, and I should know, I treated a lot of them, want to have nicer teeth because they are projecting their personality and their aesthetic appeal. So where does it all leave us? I looked at the Lux list again because I was curious about this Lux list. And in fact, in 2019, the same year the other gentleman was on the Lux list was another dentist called Dr. Alan Malouf. And one thing I loved about him was that he assisted patients with odd hours of dental emergencies and also came through on the social front, giving patients tickets to 80 San Francisco Giants baseball games per year. wow, if that doesn't get you good patients, I'm not sure what will. But sadly, the poor gentleman passed away that same year. But his sister said, and he was a dapper dentist, so in other words, he dressed extremely well. But his sister said, where he would be with Patty Hearst, Jane Fonda, Ariana Huffington, Prince Charles, I mean, he was a man with the stars. So does that make a good dentist, was the question. So the key question for the first part of this lecture is, what makes a good dentist? And having been a very long time in dentistry and in extremely successful practice, and having given over 1,000 international lectures and produced papers and changed a lot of the way dentistry is taught and examined in the UK, I came to the conclusion that being a good dentist, you need good contacts, because good contacts make a big difference. Yes, because people come already trusting you. Good marketing is very useful, because good marketing adds to the feel-good factor of your staff, not just your staff, but also your patients, because they think that you are somebody important. A good personality is extremely helpful, especially when you come to cosmetic dentistry, because cosmetic dentistry is absolutely filled with patients with different perceptions to you. And if you can get on with them, you can convince them, you can discuss with them, you can empathize with them, and they can empathize with you, your work will be much better than if you just produce good work alone. The emotional, intellectual quotient, the connection becomes so important. So a good personality, a gentle, kind personality, all makes a difference. Good clinical dentistry is very useful. I've seen lots of extremely successful patients, dentists, whose patients I've had to reconstruct. So being very successful and very profitable and very wealthy does not necessarily mean you do good clinical dentistry. In fact, there are some very famous names, dentist work I've had to rechange. But having said that, if you did good clinical dentistry, it's more than a bonus, because then others, your colleagues, will realize how good you really are. And finally, good peer-reviewed credentials. Good peer-reviewed credentials, I think if you're on your pathway to proving yourself in this world and you're starting out, is extremely helpful. Having additional proper qualifications, not by the post fellowships, but real, structured, peer-reviewed education, it all becomes important. But you could make a very good living, a very good life, and be a fantastic dentist with any of the above, but I would think that you would prefer to do it with all of the above. And that's really why we have this College of Medicine and Dentistry, and Professor Al-Mazri is very keen on young people with open innovation, challenging minds. We love to be challenged. We do not teach you like an undergraduate establishment or an undergraduate school, which is now postgraduate produced. We are mostly clinicians. We've been there. We've learned from our mistakes. It's from our hindsight that we have generated our insight. And we will teach you. I mean, the field of occlusion is built on lies about lies about lies about lies. There's hardly any evidence in most of dentistry. Much of the evidence is based on your experiential learning. And of that, we have plenty. And we will challenge you, and we will expect you to challenge us as well. Now, let me challenge you on this. What is this? Is this cosmetic dentistry? Do you think this is cosmetic dentistry? What about this patient? This patient turning out to be this. Is this cosmetic dentistry is my key question. Is this what you look at and think, wow, I wish I could do this? Who matters in this work? Who is the person who did this cosmetic dentistry? That is the key question. Whose work are you showing? Because the illusion needs an illusionist. To change a mouth from what it was to what it is, you need someone who is exceptional, who does that work. Is it the dental technician in the work I have shown you? The answer, I'm afraid, is not. It's got nothing to do with the dental technician. is to do with IT consultant. That was to do with my son, who is an illustrator and animator. And he works a lot with Photoshop. But I can definitely confirm to you that my work isn't Photoshop. My work is real, honest work. They're on analog slides. Beware of international speakers, Mr. Howdy Doody, who come and sell you their beautiful dentistry. I can almost guarantee, because I have given lectures right across the world. You name a country, I've been there. And after our lectures, we sit at the bar and we have a drink and we have a natter and we have a laugh. And by and large, I can tell you, you are seeing touched up photographs. Yes, Adobe Photoshop is fantastic. When you finished our course, go and buy this. Maybe you might have to adjust one or two of your work. You see, Photoshop teeth. How, you have to take a double look to see that they have been Photoshopped. The art of this is phenomenal. Beware of lectures on cosmetic dentistry. Yes, the art of deception. What you see is not what you get. So I would say, don't despair about your work. Yours is real dentistry. And if you're honest about your real dentistry, we can teach you to make it amazing and exceptional. So what about dentistry and aesthetics? What is beauty? Beauty is truth. Truth is beauty. That's Keats, our great poet. Anatole of France said it was more profound than truth itself. Yes. The Symmetry of a Beautiful Face by Stéphane Marcotte, a plastic surgeon. So to get this beauty, most people say, oh, I use the golden ratio. Now, what is this golden ratio? Whatever it is, I can tell you it is the position from which you look at. You can create a golden ratio for anything as long as you're willing to turn your head in any one direction. In fact, the science says it's rubbish. It doesn't affect teeth. It doesn't apply to teeth. So a lot of the stuff that you go back on and you look at and you were taught, and people wax lyrical, is all lies. It's mocon after mocon. The problem with aesthetics is, as a human being, the dentist can see more than 3 to 5 million colors, but we don't have the vocabulary to describe it. And some people are better able to translate it than others. Certainly women are known scientifically to be better than men. So my nurse always helps, and luckily for me, in my practice, my technician was. We both work together in the same building. And the responsibility is well passed on to your technician. And I need help in the form of a background support. And if you're looking at a shade for more than 5 seconds, your rods and cones have already tired out and you get the wrong feedback. So 5 seconds is the maximum time you have to make a decision on a shade. Otherwise, you've got to go away and come back again. And shade taking is extraordinary. It's all about lighting conditions. Now, the lighting conditions in the UK is different to your lighting conditions in Dubai or in Turkey. Our lights are northern lights. We do not take our shade taking in daylight. We need a bluer light source for British patients. So it is different. And remember, your visual acuity is just 5 seconds, 5 seconds, and it moves on. And of course, some people are colorblind. You need to check on color blindness. And of course, a large percentage, 40% of males have some degree of color blindness. That's why women are better than. And after 15 seconds, definitely all your receptors tire. So, and also shade guides, they're rubbish. Let's look at the Vita shade guide. Why is it that the world has Vita shade guide? The reason the Vita shade guide is worldwide and used by all of us is that when I graduated as an undergraduate, long before many of you were born, is that they gave all dentists a free Vita shade guide. The reason every dentist got a free Vita shade guide, because dentists are mean people. We don't want to spend money if we can help it. The reason we got a free Vita shade guide was because Vita then knew if we prescribed a Vita shade A2 or A3 or whatever, the technician then had to go and buy the Vita porcelains. Brilliant, wasn't it? Brilliant. Yes, manufacture a car, Give the car free, but let it run on a particular type of petrol, which nobody else has. You made your fortune. And the Vita Shade Guide is rubbish because the way it is arranged, A1, A2, A3, A4, is nothing to do with teeth. Teeth are about value. That's why composites are so brilliant. Composites are metameric. Metameric means they can disappear into the mouth. That's why acrylic dentures look fantastic, even if you get the shade wrong. You have 5 shades for acrylic dentures. They all look good in anybody's mouth. Porcelains, you have to really work hard because they are not metameric. You have to build them in. All because their values are not as phenomenal as acrylics. So composites' greatest success is because it's made of acrylic, methyl methacrylate. Yes, bis-GMA, bisphenol A, glycidyl methacrylate, UDMA, divoclar product, urethane dimethacrylate, even adhesives, 4-meta, methacryloxyethyl trimelylate anhydride. Everything is a methyl methacrylate with a bit of epoxy resin, a whole lot of fillers thrown in to reduce the shrinkage, and voila, you have a material that blends in the mouth. The only reason it looks bad is because you don't know how to use it, and we will teach you how to use it. There are small secrets that make big differences. You don't have to spend more than 10 minutes to make a beautiful aesthetic posterior composite filling. I mean, the preparation takes time, the adhesion takes time, the first layer takes time, but the aesthetic finish, we don't use burrs at all. Teach you how to do it. Looks like $1 million. Nobody will even know that these are composite teeth. And they are great because they are metameric. They disappear into the mouth. Most of the time, dentists get it wrong because they don't know how to make it disappear into the mouth, because these materials want to disappear into the mouth. So if you have a Vita Shade Guide, please rearrange your shades. You'll find life so much easier. Start with the B1 first, because this is on value basis. You'll find your shade taking improves so many %. And now you'll find the modern Vita Shade Guides and all based on values. But in any case, what is aesthetic? I mean, the Mayans thought this was aesthetic. In this century, I mean, I've lectured in Kazakhstan and other countries, and dentists have shown me some of the teeth of some of their local communities, their local tribes people. And for them, getting teeth like this is aesthetic, not our concept of aesthetic. Concept of aesthetics is unique to that individual, to that culture, to their upbringing, to that nation, amongst lots of other things. So this is that plastic surgeon's patient. Is she beautiful? Is she beautiful? Or is she beautiful? It's the same patient, same width. All I've done is elongated it. Beauty is in the eye of the beholder. So by and large, if you can speak to the coconut of the patient, if the patient is convinced about you, a lot of your aesthetic dentistry becomes so much more easy. But if you're a patient who has personality problems, who really look like the back end of a horse, yes, who are trouble or waiting for trouble, you ain't going to get it right. These people with body dysmorphic disorders, amongst other things, will always be a cause of problem. It's a mental problem. You really don't want to practice mental patients. You know, there are 7.5 billion people out there, more than enough for each and every one of us. In the UK, we are crying for dentists. We don't have enough dentists to fix cases. Remember, you don't have to treat everyone, because there is always somebody out there who wants to treat everyone. Let them treat it. You don't be a fool. Let's show you some other bits. It'll dovetail into the lectures of my 2 other colleagues or 3 other colleagues, yes, of today. So this is a patient who came in to see me, and he was getting on a bit in age, but he was being honored by Her Majesty the Queen, just as I have. I'm grateful for that. And he was going to give a speech on a very important occasion. And of course, patients like this, very easy. It's a 15-minute makeover. You don't use a burr on these patients. You use a scalpel. You use your composites, any shade, the shades you never use on real composite cases, because you're going to do a trial composite run on this patient. So you just pop on a bit of composite, Yes, you pat it in with the back end of a scalpel. You get the nurse to zap it for 5 seconds, 2 seconds, 1 second, and then you shave it with your scalpel blade, and you just keep adding it. You just keep adding it and you shave it off. No acid etch. You just flick it on the teeth and you tell the patient, is this what you want to look like? Yes, that's on the first visit. You've had your consultation, you've done your exam, or the whole lot, and then for 10 minutes, 15 minutes, you just bopped it because you know you can whip it off if the patient didn't like it. And you ask the patient and you tell, take it home and try it out. Take it home and try it out. And the patient takes it home and tries it out. And usually nobody ever notices because people at home, which is their family, love the people who are in their family. They don't notice little things like this. Usually when I do a full mouth reconstruction, and my practice was based on the foundation of full mouth reconstructions, I ask a patient after I've cemented it in provisionally, what did your family think? If a patient said they thought it was wonderful, I'll take it off and do it again. Because reconstructions, aesthetic dentistry should never be noticeable. If it is noticeable, there is something to be noticed. It is different. So a patient goes back, nobody's noticed it. What happens? Within 24 hours, 48 hours, 3 days, it all starts falling off. Bits fracture off. That's when you make your sale. When bits fracture off, it looks so horrendous, the whole family realizes how terrible the teeth were. Yeah, when it falls out, that is when the difference is noticed. But what have you forgotten here? What has been forgotten here? I've done the anterior, I've got the aesthetics, I know what I'm going to do, but what have I forgotten? Yes? Well, I take you to a litigation case. So I was expert witness on several cases. I served on the General Dental Council, I served on disciplinary committees, all kinds of stuff. Yes, I worked for the Lord Chancellor, for 18 odd years, being one of the three wise men to help appoint judges and magistrates. Yes. So litigation and the law is part and parcel of what I know. And hence, that's what I will finish on at the end of this lecture as to what you need to watch out for. So this was a case. The patient was sent to me because the patient was unhappy with her teeth. When I asked her, what is it that makes, so the lawyer sent it. So I asked her, what is it that you're unhappy with the teeth? Is it the appearance? She said, no, it's much better than my previous teeth. Is it the color? No, it's much, but there's something wrong. There's something wrong. I don't know what is wrong. And of course, if you've just heard my good friend and colleague, Professor Ziad's lecture, you realize what it was. The anterior guidance was changed on that patient. The patient's teeth are not just about occlusion, it's also about disclusion. The anterior guidance was missing. So this is my car. And in fact, it looking very pretty outside my house does not matter as much as how it functions. Looking pretty alone isn't enough, because if it doesn't function well, you'll be having some people to tow your car away. Yeah, you need both aesthetics and function. And in occlusion, it's function and dysfunction. It's occlusion and disclusion. Occlusion is the bringing of teeth together. That's done on verticulators. Disclusion is what's done on articulators. It is taking that, and you may not understand the significance of it because a lot of occlusion is built on lies. We will explain to you and teach you why these things matter and whether there is any science behind it. I can tell you there isn't much science behind it, but practically speaking and legally speaking, it helps a huge amount. So it's a bit like this. A mandible is like a three-legged stool. When you put an anterior deprogrammer, yes, it moves like a three-legged stool, and that's how you find centric relation. Centric relation is a bad position. It's an artificial position. You don't want it, but you want to relate to it. And when you close, it's like moving the three-legged stool back to its original position. So that's the concept that most people don't understand, including academics. And we will teach you to understand it, because once you do that, you find life different. And once you understand where disclusion is, you want to capture it. The most important part of an articulator is its incisal guidance table. So here's one of my patients where the disclusion has been captured on a incisal guidance table with Durelay, as explained by Professor Ziad. Yeah. Posterior stability and anterior guidance. That's the story of occlusion and disclusion. Mustn't forget it. It is so important. Manufacturers have pre-planned this as well as mechanical alterable tables. So this is KVOs. So I actually was with Walter Lang when he was inventing the Digma. And I contributed to some of the thinking behind it. It's a 4-dimensional Facebook record. It's totally different from an arbitrary Facebook. We have one at the College of Medicine and Dentistry, Digma 2. I had the Digma 1 because, of course, I was part and parcel of the original bit of, let's say, understanding of it. So this, of course, is the traditional anterior guidance table, whereby you put in a bit of acrylic and then you move it around, capturing the anterior guidance. And then when you do your final work, you copy the anterior guidance back in reverse on the palatal surfaces of the anterior teeth. Because, of course, the patient wasn't susceptible when the patient came. The patient had no occlusal problems. The fact that you allowed the technician to build the disclusion with no prescription meant now the disclusion was an interference for the patient. And the patient was never happy. Now, KVO, for example, this is a table, that's the incisal table on which you do this. See? And it's a reusable table because you can flick it out afterwards. After you've done it, as long as you've Vaselined it, you can flick it out. And then each time the patient comes back, you can slip it back on and reuse it. But there's a screw at the bottom. The screw base at the bottom actually has, at the base of it, an arbitrary anterior guidance table. And in fact, if you ask KVO, they'll give it to you at different angles. They'll give you this screw at different angles so that if a patient didn't have anterior guidance, anterior disclusion, if you were going into the provisional phase, remember what Ziad said, Prof. Ziad said, yes, it is not a temporary phase, provisional. Provisional means you're learning from it. We don't do temporary crowns here. We do provisional. We want to learn shape, color, aesthetics, function, dysfunction. So we place this. So if you had nothing to start from, without having to find a kinematic face move like the Digma, you can start with the arbitrary anterior guidance, yes, for that patient and build on it. And in fact, this is KVO's own, the PROTA's own incisor guidance table, where you can actually change the angles without needing this. So you can have it at any number of degrees. And this is Dina's, which I also have. Yes, I've had the Dina pantograph, the Pantronic, the SAM axiograph, the Digma, the lot. Yes, where you can change the anterior guidance. And you can also create long centric. You can also create long centric on this. Yeah. So manufacturers know, dentists don't know. No point buying all this stuff if you don't know how to use it, because the condylar guidance is actually an interference. It's an interference. You need to know face bows are bad for smile line analysis. Face bows are contraindicated for aesthetic dentistry. You need to understand it. We will teach you those things. And in fact, here you are. I will show you. Now here you are, you've got anterior disclusion, but look if a patient has reduced condylar guidance. Yes, when the patient has reduced condylar guidance, reduced anterior guidance, ends up with posterior interference. So you need to know what this is in relation to this before you can undertake the treatment on this patient. So I come to a different case, severe tooth surface loss, you know, a youth spent with misused drugs and all kinds of things. And that's what she was in her teens. And very soon she went around like this. And we are, of course, going to reconstruct her somewhere along the line. And those are the teeth. And what I do when I have time at lunchtime is, you know, all these old composites that you have, which has expired. Everybody has expired composites, don't they? Yes. I mean, when manufacturers sell you a box of composites, you have shades that you will never use even on a monkey. And of course, they've all expired. What do you do with them? You can't send them to the third world. They've all expired. So what people like me tend to do, because I know composites are metameric, yes, have a chameleon effect, is that I use these and I do my own diagnostic PAXA. So I sit there, and usually it's my nurse who sits next to me, and she's with the zap. She goes 2 seconds zap, 2 seconds, and it's all done with a scalpel, just like in that other patient in the mouth. Yes. And then what you do is you make a quick pull down template. You don't even have to make plaster models. You do a quick pull down template. And when you show this to the patient, put your thumb over it. If you put your thumb over it, the shadow will make all these colors blend together. So remember, this patient has tooth surface loss, which is very severe. I built it up with composites, just scalpel blade and old composite expired stock. Yes, because that's not going into the patient's mouth. Yeah. And then when I show it, I show my thumb over and the patient, oh, that looks all right. That looks all right. Looks like my picture. And then I make a pull down template. Yes, a suck down template on that itself, because I don't need to make a plaster cast. And then I fill it full of composite, stick it over the patient's teeth, no acid edge. Use a scalpel to just trim off the excess. Couldn't care less what the margins were like. Tell the patient to go home. Yes, take it home and try it out. It'll fall out. But when it falls out, the impact is so dramatic because they say, what's happened to your teeth? What's happened to your teeth? Yep, they'll want it fixed. I can tell you, they'll want it fixed. Of course, on that first day, I also made an arbitrary mock-up. And so when the patient comes back, I'm going to do it provisionally because I'm going to do fixed work on the patient. Yes, I know my colleague who started off, Professor Mehta, was extremely gentle, kind, and so on. But I'm on the last train home with the patients in their last stage of life. Can't faff around. They can't go into care homes and end up keep coming back to see me. So I'm cut and thrust. But I go through the intermediary phase of plastic restorations from which I learn and then I replace it. Yes, so here you are. So this is my quick fix. Doesn't take much time. I use the silicone index. And what do I do? I build up the aesthetics. Lamella built up. It takes no time at all. 5 minutes a tooth, max. Then palatally, I don't use composite. Composite is a nasty material. It's lovely aesthetically on that day. It hydrolyzes, it breaks down. It's also a petrochemical product, which makes it a known carcinogen. That's why it kills pulps. Don't put it near pulps. But nevertheless, it's very pretty on the day you put it in. But it's also made of sandpaper. Composite is resin and filler. Filler is sandpaper. What's the sandpaper you use to sand your walls, to sand your car, to sand your shelves? Same stuff as composite. Resin, filler, resin and sand. This is man-made sand and resin. So composites, so therefore in patients who are clenching parafunctionists, composites are bad material to even build up teeth because it beats the living daylights out of the opposing tooth. So you're putting composite, put it against composite. But most people parafunction, so it's not a problem. Parafunction is universal. Seligman and Pullinger produced that paper back in the 1990s, and Pullinger and I have lectured together across the world. And as he says, it's common. Parafunction is natural. It's a good thing. It's a stress relief. Much rather parafunction than kill your partner. It's when you clench and parafunction, it becomes different. That's a different kind of occlusion, a different kind of reconstruction. And you need to come to us for us to teach you how to undertake clenching parafunctions. In the meantime, in ordinary parafunctionists, because everybody parafunctions, you don't want to put composite on the palatal surfaces of discluding teeth. Because discluding teeth protect occlusion. Occlusion protects disclusion. Back protects the front. Front protects the back. Disclusion protects occlusion. Bang, bang. So if you're going to have disclusion, you don't want it to start wearing the opposing tooth. So we use something softer, a bisacral, which can bond to composite, or a compomer. So we place on compomers for the palatal, and then we let the patient go home and function on it. We just leave it with the patient. So now we wait and wait and wait. If it keeps falling off, we know we haven't got the occlusion right. We haven't got the disclusion right. So we go and make some adjustments. I'll show you lots of cases for wide centric, long centric, yes, the really complex ones. Yeah. So we allow the patient to work it out by themselves on their own time instead of our time. And once they have now created their disclusion, everything is good. We then take study casts of our temporary work and we construct the anterior guidance table. Now we can go back and copy the final crown and bridge work to this. So remember, Don't forget disclusion when you do aesthetic dentistry. But that's not what my lecture is still about. It is part, it's the middle way. So I'm telling you, aesthetic dentistry, if you're going to go down that route, and that is what you have marketed yourself as, don't forget function and dysfunction. Being pretty alone isn't enough. The patient must not come back and sue you for something nobody understands. And what else have you forgotten? My good friend and colleague, Professor Ziad, hadn't forgotten. It's fremitus. All teeth will have fremitus. Why do you have fremitus? Fremitus you have fremitus. So that is when you put your finger on your tooth and you bite together. All of you, if you put your finger on your tooth and bite hard together, go tap, 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 tap on your posterior teeth, you'll find your front teeth move. And the reason for that is because of not just differential mobility, but adaptive mobility of the teeth. Teeth can be intruded by almost 60 microns. So you have 3, 4, 5, 6 shim stocks worth of movement. You can have that much movement of the lower teeth hitting the upper teeth. And that's why for veneers, on patients who are parafunctionists, who have moving teeth, and everybody's teeth move, they move between 20 to 60 to 80 microns in 3 dimensions. Imagine, just think about it. Veneers are stuck on the front of the teeth. Why do they fall off? They're not in occlusion. They're not in disclusion. The reason they fall out is because of the judder on them. The judder on them. The fremitus on them. When the fremitus hits, the veneers are stuck on with only micromechanical retention, tiny bits of retention on the retipegs. And usually you're putting veneers on some other dentist, stupid veneers, where he's removed all the enamel. Only enamel has the retipegs. Dentine does not have it. There is no dentine retention. When you come to adhesive dentistry, you realize dentine has no bonding. Dentine bonding is a fudge. And a lot of the many generations of bonding agents are there to reduce your time and effort. And it's very good for most patients because most patients are okay. It's like parafunctioning. Everybody parafunctions. It's like plaque. Gingivitis is common to everybody. It's not a big threat. Periodontitis is totally different disease to gingivitis. Totally different. It may not even be due to plaque. But that's a different lecture for another day. So like that, same again with fremitus. If you don't have enough enamel, you don't have micromechanical retention. Your veneers will keep popping off. So that's why you overlap it palatally. So you end up with macromechanical retention. To get micromechanical retention, the composite must shrink to lock against the retipegs. That's the retention. The retention is mechanical. It shrinks and locks. It locks into the tiny enamel retipegs. That's why you don't etch for more than 10 seconds, 15 seconds maximum. Because if you over etch, you've left too many dead spaces and then the bad color gets in from your coffee and tea and it looks terrible. So you etch sharp, etch flash, bond quick. But of course, if you don't have any enamel, you can't rely on dentine. Dentine is rubbish. It doesn't stick. The whole idea is to not allow it to push the composite out. That's why you have wet bonding. And because dentists don't know how much wet is wet, they incorporate the wetness into their hydrophilic monomers. Yeah, it's all very clever stuff. Yes, to try and make their product sell. That's why you wrap it over. Once you wrap it over, there's micromechanical retention of the enamel retipegs locking, but there's macromechanical retention of the entire composite locking. The entire adhesive locks on itself. And that's the reason why you lap over the incised ledge. Huh? See? Free lectures. Come and learn the real things. So, but really, at the end of the day, go and find the best technician you can't afford. And you create a career with that person. I was very lucky. My technician came from the Lebanon, Nadim Kurban. He was Peter K. Thomas's own technician. And most of the work, if not all the work I show you, will be Nadim's. I just take the money. So as a dentist with a team on song, you need the right information regarding the smile line, good study cars, gingival tissue control, sound tooth preparation will teach you to cut like gods. That's if you come to the crown and bridge section. Of course, Shamir will teach you the adhesive part of it, and that will be brilliant because he's brilliant. Yes? and Ziad, we all know is already brilliant. Yes. And of course, the functional prescription of pathology with Ziad as well. Yes, diagnostic provisional, see, not temporaries, chair-side characterizations, patient participation means we talk to the coconut of the patient, correct selection of materials placed correctly, and we'll teach you about all the different materials, why some are rubbish, some are not. But we have to use rubbish in some circumstances, whether we like it or not. It depends on who that patient is. It's never what the problem is, it's who the patient is. The who the patient is far more important than what is the problem. And you need an excellent citation, but that's still not enough. That, I'm afraid, is still not enough. So what's missing? This is the paradigm shift. The world has changed, certainly in the West. It's a major change in how people think and get things. Yes? We can't sell origami when patients expect a swan. The game is changing. I should know. I was at the forefront of seeing all these changes happen, thinking, oh, by the grace of God go I. I could have been there. I could have been there. Aren't I lucky? So really, silence does not equal consent. Consent in the Western world has to be informed and understood. But that's not all now. I mean, we know that, but it's more complex than that. Yes. You see, the legal framework has completely changed because there's new law coming in. It's all about previous case law. And the case law is changing rapidly all the time. I'll bring you up to date with it. And this is Paul Tipton, a very fine dentist, who said dentists are seen as easy pickings by the public and solicitors. And there's been a phenomenal rise of dental negligence cases. So much more litigation. A lot of the time you look at it and you think, gosh, it's not that bad. But yet, it's not very defensible. We got to pay up. And once you start paying up, defense societies will charge you more for your indemnity insurance. And it's a mandatory requirement in the United Kingdom and many of the Western countries to have indemnity insurance. And sometimes it can go into 30,000, 40,000 pounds a year for people who have not perhaps because they have intentionally made a mistake, but have made a mistake that they maybe shouldn't have. The old test, the Bolam test of 1957, that was due to a person who needed to have shock therapy because he was mentally unstable. And the doctor who gave the patient shock therapy did not tie the patient down on the chair before the shock therapy was given. So when the shock therapy was given, the patient flew off the chair, hit the floor, broke the hips, sued the doctor. Case went to court. Court said, ha, 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 ha. Doctors are always right. Just because some doctors might tie you in, it doesn't mean every doctor has to tie you in because some doctors don't tie their patients in. It's your fault for jumping off the chair and breaking your hip. I'm afraid that era is gone, finished, over. We got a shock when the next era came, which was the Hux and Cole in the Court of Appeal. And there it was said the courts must be vigilant to see whether the reasons given for putting a patient at risk are valid in the light of any well-known advance in medical knowledge or whether they stem from a residual adherence to out-of-date ideas. In other words, if you felt you didn't have to tie a patient in, when the knowledge said you did have to, then I'm afraid you're stuffed. But it took almost 10 years, more than 10 years, for that to come about. But that's not all. The Bolito case came. And the Bolito case came in and said, excuse me, there may be a body of opinion which is saying this. There may be another body of opinion saying this. And both bodies of opinion, one from the Royal College of Surgeons of England, one from the Royal College of Surgeons of Edinburgh, well, aren't they Royal Colleges of Surgeons? Aren't they from England and Edinburgh? I mean, I was a dean at the Royal College of Surgeons of England at one time. Yes. Who is right? Of course, I would say I'm right because I'm from England. Edinburgh would say they are right. But the judge said, no, the body of opinion must also be shown to be reasonable. And who decides that is the question. And the decision is made by the man on the Clapham omnibus. It's not made by the profession. We take professional views. I'm sitting from the Lord Chancellor's chair, the judge's chair. We take the views but the decision is mine, or it's the decision of my jury. They must think which opinion was better. Oops. But it's moved on even further than that. Huh? This is James Garner and Doris Day. You won't even remember them. They're probably dead before you were born. Huh? These were in my time. Move On, Darling was a lovely movie. The Montgomery in 2015. It was all about medical paternalism. In other words, it said doctors really cannot talk down to patients. Patients are autonomous. They have freedoms of independence, of choice. They should decide for themselves with all the information provided. So this was against the Lanarkshire Health Board. And what it actually said was, patients must make the decision. A reasonable person, a patient is considered a reasonable person. A reasonable person in the patient's position would be likely to attach a significance to the risk, or the doctor is or should be reasonably aware that the patient would be likely to attach significance to it. So you need to tell them almost all the risks that a patient might consider significant. So now you can't turn around and say your tooth might die because I'm using a composite. I mean, nowadays you can't turn around and not say your tooth might die because I'm using a composite. You will say that because composites are petrochemical products. They are known mutagens, they are known carcinogens. That's why more bacteria grow next to composites than they do against amalgam. Amalgam is micromercurial poisoning. Amalgam is not adhesive. There's always a gap between amalgam and the tooth. But amalgams leak a lot less than a composite. Why? Because no respecting bacteria is going to grow up their children under a micromercurial toxic time bomb. But they love composites because composites are petrochemical products, and that's how evolution takes place. You have a mutagen, your children are going to have 3 heads and 5 hands. Isn't it wonderful? Far more attractive kids. So that's why most composites, once they start fracturing off the adhesion bit, are something where bacteria love to breed. Yeah. So you should be able to turn around and say, these are actually toxic to the pulp as well. And when you come, we'll teach you about the pulp, how the pulp defends itself despite you. And why it is you use an aerotor and not an electric micromotor to cut teeth. Now that's interesting too. Why buy an aerotor when you can buy a cheaper micromotor going just as fast, but you don't cut teeth with that? Wow. Then the Muller case, the last I will show you. There are others in the pipeline. And this is against King's College Hospital NHS Foundation. But they turned around and said, you can't take an overview like that. You have to break it in two. You have to take it as a diagnostic question. First, you must find out whether it was wrong at the top. Then you have to decide whether it was wrong at the bottom. Double jeopardy. So the first type is when a patient's condition is unknown and the diagnosis is either right or wrong. If wrong, is it negligently so or not? And this was to do with some histological work that was done. The second type is of pure treatment, where the nature of the patient's condition is known and the alleged negligence consists of a decision to treat or advise treatment of the condition in a particular manner. In other words, it's a two-step process now. So whether the medical practitioner acted in accordance with the practice accepted as proper and ordinary, competent medical practitioner by a responsible body of medical opinion, which is decided by an individual who is not a medical person, and whether the practice survives Bolito's judicial scrutiny of being reasonable and responsible. Whoa, that's a change in life, isn't it? So I'll show you a case. This is not mine. Picked it out of the internet, and I show it to my students. And this patient came for aesthetic improvement, I believe. Yes. And I show the work that was done. And it really does look nice. I mean, no, it's enviable. Yes, I mean, there's a bit of gingival inflammation. And one of the reasons you have gingival inflammation is if you're using adhesive dentistry, the adhesive leaches out from behind your veneer. That leaching out from behind your veneer hits the gingiva. Some patients' gingiva are more sensitive than other patients' gingiva. And that's why you have persistent inflammation after you've cemented adhesive dentistry. Adhesive dentistry, if you're going to cement anything with adhesive dentistry, make sure you put a barrier on the gingiva so that if it's a retraction cord, which is very lightly placed, that picks up all the adhesive and you whip it out. Make sure you polish the margins well from the adhesive, because as long as the adhesive is there, you can't see the adhesive. It doesn't stick to the dentine. So because it is gingival and it is root surface and it is cementum, it can't bond to the cementum, but it overlays the cementum with small adhesive bits, a bit like Velcro. And inside these Velcro bits will be the bugs. They can grow there. And the Velcro itself is an inflammatory material. Composites are inflammatory. Yes? Next time you have a cut on your finger, put a bit of composite on it. Hurts like mad. Nasty product. Composites are high allergens. They go through gloves to produce the allergy. So you want to make sure that the gingiva is well protected whenever you use adhesive dentistry. Because if the material gets underneath there, it's a big problem. Because the gingiva can't heal very well. Now, I showed you the before, I showed you the after, and I said they were lovely. My students all think they're lovely. Now let's show you the intermediate slide, the one in the middle. Now what do you think? Now, if you showed that to the patient or the patient's family, would they have approved of this? When really, your colleagues would have turned around and said, why don't you just add a bit of composite here? Pop the inside little and send them to Wyman Chan. Get Wyman to get the teeth white. Our Professor Chan is a miracle man. And you just add a bit of composite. Send it to Professor Shamir. Done. You don't even have to send him to Professor Ziad because, of course, you haven't changed the palatal occlusion at all. Yeah? Now, what do you think? Now, this is a potentially serious litigation case. You can turn around and say, oh, I don't have this cast. I don't have. You need to. Baseline records are compulsory, are mandatory. If you're going to treat a patient whom another person might think is harmful, you needed to have had the evidence to show that you handled. In the absence of it, well, whose word is going to be taken? Here is Martin Kelleher, an old adversary of mine, just retired from King's, one of the finest pairs of hands in dentistry, one of the most brilliant speakers. If ever he can, if you ever come across lecturing, him lecturing, please go and listen to him. Outrageously funny, marvelously practical, and shows superb work. And he said, and this is in the journal published by the Royal College of Surgeons of England, which is very close to my heart. That's the Faculty of Dental Surgery's journal. He said, the blatant destruction of teeth apparently are being undertaken to cure patients affected by porcelain deficiency disease. I mean, what a powerful statement. Why are you removing sound, good enamel, Raj? He said. Do your patients suffer from porcelain deficiency disease? Why do you want to replace good enamel with porcelain? Is that a disease? He went on to say this is a newish disease identified by some dentists who also seem to think that teeth suffer from hyperenamelosis, an excess of enamel. It's a new term coined by him, hyperenamelosis and porcelain deficiency disease. He wanted to say, it probably goes without saying that both of these conditions are imaginary, fictitious. Yet it appears to me at times that they are perceived to exist by some cosmetic dentists. Now he sits on the board of our largest indemnity society, the Dental Protection Limited. Double mugging of these patients. These unfortunate patients are being robbed twice, first of their money and again of their enamel and dentine. So if you are coming to Britain to work, take heed of what I am saying. And we will teach you that. You may turn around and say, but the patient insisted, the patient wanted it, the patient swore they will not sue. Here's a patient, here's a fictitious patient who came and said, my daughter is getting married to a prince in 10 days' time. Can I have great teeth for the wedding, please? And you look inside the mouth, and this is what you see. And you say, oh no. She says, no, I don't want dentures. It's 10 days, just put bridges in there. I know they will fail. I'll lose my teeth. I will sign any indemnity. And she signs, I know my teeth will fall out. I've insisted that you undertake the crown and bridge work. I am happy to pay for it. Here is the money up front. Please do the work. I absolve you from any litigation. Witness, signed, sealed, handed over. Doesn't work. And doesn't work. patients cannot write away their rights. It's a bit like buying something from John Lewis, one of the best department stores here. And they say, I'm afraid we can't give you a guarantee on this because it is something in the showroom. I'm afraid if it fails within 1 year, you still have the guarantee. You cannot sign away the guarantee. If you're asked by a patient to undertake treatment that you believe is unnecessary, you must act in the patient, because only the patient doesn't know, only you know. Only you know. And the patient will come back and say, my bridges have fallen out. It's only lasted 3 weeks. But I said, I did tell you it won't last. Ha, 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 ha. What do you mean? You signed an indemnity. That's not worth it because I didn't know all the reasons. Yeah. Do not undertake treatment that will cause permanent damage to the dentition or will be of no clinical or cosmetic benefit. This is after work from people like Professor Aubrey Shyam, Professor Richard Elderton, and all of the others. They turned around and said, people who didn't go to see a dentist regularly ended up with more teeth than people who went to see dentists regularly. We were the harmful people for patients. If the treatment fails, the patient may seek damages. And finally, a signed statement from the patient instructing you to carry out the treatment and absolving you from any of the stated adverse consequences may not provide a valid defense in the court or before the General Dental Council of the United Kingdom. So times have changed. You will need to practice defensive dentistry. And defensive dentistry is not a bad thing. It is not against the patient. It is to protect your reputation. And if you are a student of our College of Medicine and Dentistry, our reputation, because our reputation will lie in your hands. And therefore, we have an interest in protecting you, and you must have an interest in protecting us. The world, certainly in the West, has changed. It has become far more litigious. And I would tell you without any hesitation that you will need to think when you put yourself out as a cosmetic dentist of all the consequences, not just aesthetics, not just function, but also how it will stand up to scrutiny. So therein lies not one paradigm shift, but several when it comes to the care of a fellow human being. I hope it's been food for thought. I'm allowed to be outrageous, but I'm not. It is what it is. Well, I hope I get to see some of you at least at the college at some point in time. And I hope you've had a very good conference. Thank you very much for having listened in.
Thank you very much, Raj. That was as entertaining and enlightening as always. I always really enjoy hearing you speak, I have to say. Has anybody got any questions for Raj that they could put in the chat box?
Any questions? I can't find my chat box. You'll have to read it out to me.
No worries. Nothing's come up yet. Somebody's thanking you for your great lecture. Thank you for your much energetic presentation.
I can tell you at my age, if it wasn't energetic, I'll probably be dead.
Any questions for Raj, anybody, before we let him go?
Well, all it leaves me to say is thank you all, guys. And I hope you have a wonderful, great, and superb career.
Thank you very much, Raj. No doubt I'll see you soon.
Cheers.
So thank you, everyone, for today. I think it's been a really informative and excellent day. I've really enjoyed it myself personally. If you do want any more information, obviously you can contact the Knightsbridge Academy at info@kbac.uk. For any information on the courses from the College of Medicine and Dentistry, it's a similar email address, so info@comd.org.uk. So if there's any questions or any further questions from that, just email either of the email addresses and we'll be able to assist you and get them answered for you. I think that's it from us. Is there anything that you want to say, Bulent, before we sign off?
No, thank you very much, Andrew, for your effort, for your great introduction.
Thank you.
See you next time.
See you next time. Thank you, everyone.
Thank you. Thank you for everyone.
Thanks.